Verdiana, are you in?
Yes.
The voice is, there are problems with the voice. There is an echo.
Yeah, Uncle, can you hear me? Now, can you hear me well?
Much better.
Okay, great. So we have now almost all the panelists, around six attendees. So we're starting at 10 after 10.
10 past. Yeah, again, it's not clear, the voice.
It's not clear now?
Well, not perfect. I mean, I don't know. We can ask the others if the voice is clear or not. Maybe
Your
Lisa. Perfect, clear. Okay, so it's my problem. Wait.
So good morning, everybody. It's really a great pleasure to be part of this important international workshop on the use of summary measures of population health for priority setting. That even if online, I think, and I'm sure about that, it will be of high scientific value. Before to officially start with the presentation, I would like to share with you some technical rules that will help us in attending all the session of this meeting. So first of all, please mute your microphone during the workshop as well as the video. And if any questions or comments, please use the chat or also the right hand button. On the right, you can also find the details on how the Zoom platform works. So please take note of it, and thank you for your collaboration. So, having said that, let's focus on the content. As we anticipated at the beginning, this is an international workshop aimed to discuss in a roundtable of experts on the summary measures to population health to lead the priority setting in health policy making for the payer perspective. And the debate is based on the needs and challenges of health sector transformation program in Saudi Arabia under the Vision 2030. And we will take advantages from the valuable experiences of colleagues and professors invited today. Regarding the objectives of this workshop, they are several. Firstly, we would like to explore methods, challenges, opportunity of using the summary measures population health in policy making from the payer perspective. And we would also like to present and show lessons learned from some study cases. And in particular, we would like to focus on how the results sustain health policy making. Then we will discuss the methodological aspect with a particular focus on the need of data culture, and then on how to innovate priority setting and resource allocation through the summary measure of population health strategy. The agenda of this workshop is divided in 3 thematic sessions. So the first, each of them will take 1 hour and a half approximately. So the first one will be about priority setting in healthcare systems from the Payor perspective, then the national and international experiences of core summary measures of population health, and lastly, the method, challenges, opportunity of summary measures population health. We will conclude the workshop with a roundtables, and in particular, please take note that each speech should be last for 20 minutes in order to be tight with the time, and to have also the time for a short questions that we can have at the end of each speech for approximately or no more than 5 minutes, because the larger part of the questions and answer session will be, so the discussion will be performed during the roundtable, so at the end of the workshop. During this workshop, I will co-chair with and share the chairing with the Professor Carlo Signorelli and Dr. Abdullah Khoja. Professor Carlo Signorelli is a full professor of Public Health at Vita Salute San Raffaele University in Milan, Italy, and Dr. Khoja is Associate Professor and Consultant of Public Health and Family Medicine at the College of Medicine at Saud University. Now I would like to invite Dr. Hussam AlFaleh and Dr. Abdulrahman Saad Alqahtani for opening remarks and introduction. Dr. Hussam AlFaleh studied abroad as in Canada, Nova Scotia, and Germany, and in 2017 he joined the program for health assurance and purchasing as Chief Medical Officer before his recent appointment as Chief Executive Officer. Dr. Abdulrahman Saad Alqahtani is Vice President of Health Transformation of the Health Holding Company in Kingdom of Saudi Arabia. So please, the floor is yours.
Thank you very much for this kind introduction. It's really a pleasure to be part of this workshop. First of all, I just want to make sure that everybody could hear me, so I don't blather for about 10 minutes or 5 minutes without anybody hearing anything. That's great. So it gives me a pleasure to be part of this. I will try my best to attend as much as possible of it. Given some of my commitments, I may not be able to. But first of all, I just want to say a few things about give you some context. And I'd like to go back maybe 4 to 5 years, and I think Dr. Abdulrahman and myself, we've been part of this journey for the last 5 years, the transformation of healthcare that is happening in Saudi Arabia. We were privileged to be part of this big enterprise. The first thing that happened 5 years ago in this new transformation of healthcare in Saudi Arabia was to transform or look into the model of care, how care is delivered. And at that time, the change in the transformation or the design of this new model of care took into account a philosophy that basically takes into account moving us from a hospital-centric model to a beneficiary population-centric model. The second thing that it took into account is moving us from this current system that is very much input-based to an outcome-based system, and to focus more on value delivery. So value-based healthcare was one of the key areas that was highlighted, or the philosophies that were taken into account in the design of the new model of care. And finally, one of the key areas and our compass in terms of moving towards this new model of care is its ability to achieve the triple aim. better care, better health for the population at a lower cost. So this was followed by structural changes that happened in the system, namely the gradual transformation of Ministry of Health that does everything, regulation, delivery, and pay and purchase and payment of healthcare, to actually forming a new payer, which happens to be the Program for Health Assurance, or CNHI, Center for National Health Insurance, that I currently lead, and the corporatization of healthcare providers, and the journey towards moving healthcare or healthcare facilities from hospitals that are disconnected, oftentimes not working together, into hopefully at the end of the state accountable care organization that actually take care of a set population and becomes accountable to its care. So in that sense, our program, the Payor FAB, is we look at ourselves and we are looked at as an enabler of this transformation. We look at ourselves as a progressive payer, or at least that's our hope, our aspiration to become a progressive payer that enables value delivery through its tools as a payer. Our aim, our mandate as a payer is to purchase healthcare services, but to take into account three key areas. One, value delivery, so high quality care that is delivered efficiently, number one. Number two, a responsiveness to the needs of the population, to the beneficiary. And then three, control of cost of care to create sustainability. These are the three areas or the three objectives of the organization, and that is why we were created. Now, what keeps me up at night, and I suspect most of my colleagues in our organization, is how is it that we're going to achieve that? And how do we fulfill that mandate that was put upon us? And what often occupies my thinking and my colleagues is how can we become a data-driven organization? An organization that obviously can actually plan care and measure care using data. The second thing that I think is that keeps me up at night is how do we enable and catalyze the transformation towards delivery of value. I think that particular objective is one of the most challenging objectives. How do we as a payer transform, enable and catalyze the transformation of the delivery model? And to meet and address the key challenges that we have in Saudi Arabia, and frankly, the challenges of every healthcare system, to actually address the burden of disease, specifically non-communicable diseases, enable the implementation of upstream interventions on specifically preventative measures, and to take into account to do that, also to take into account social determinants of health, which is often neglected. Now, that's the second thing that keeps me up at night. The third thing that keeps me up at night is how do we manage provider performance? And I think that is somewhat connected to what I just mentioned. And to do that by leveraging data, obviously, and to use progressive payment tools to actually help catalyze that transformation. Now, 4 years ago, we realized very early that in order for us to do all of that, our operating model, our clinical operating model, frankly, also of the healthcare provider, is really the implementation of population health management. I have no doubt that is going to, check all the marks or tick all the boxes really to enable us to actually meet our objectives. And therefore, in that sense, what we've done over the last 4 years, along with our colleagues from the other players in the system, the health holding company that Dr. Abdulrahman represents, is developing a manual, a strategy towards population health management. We've been really working hard in terms of addressing the issues of the assessing health needs, and also, more importantly, to try and prototype and experiment with ways of implementing population health management, because frankly speaking, population health management means different things to different people. It is practiced in different ways in countries. And what would make sense in our context is really the question. And therefore, we need to have an open mind, have a bias towards action and learning from our actions very fast. And that is what we've been trying to do with our partners in this system. So again, I'd like to highlight the fact that this really activity and this workshop is one of many, many activities that we are interested in and we're part of to actually meet these objectives. And I look forward to listening to you. And I'm confident that the participants will benefit a lot from the discussion. So thank you very much.
Thank you, Professor Hussam. Good morning, everyone. And first of all, I'd like to thank you personally, Dr. Hussam, for your patience dealing with me for the last 5 years. That's really so. First of all, I'd like also to welcome our international speakers and welcome everyone who's here with us in the call. I think it's great to have this forum. I remember like when Professor Hussam mentioned 5 years ago, when we stood in one of the stages to preach about the model of care and the transformation. And maybe at that days, we never thought of the, I wouldn't say we never, I mean, there wasn't enough talk about population health management. And I can remember last year we have, or 18 months ago, we were like few people. Maybe you can count them in your hand, who are talking about population health and how to push the agenda for population health management into the new system. And like after 18 months, you can see now we have a national forum, a national experts panel, a national strategy for BHM, and you can see a representation from all clusters who are really excited and willing to support in this journey. And it's not only the clusters or the FAB or CNHI or the health holding company. It's even outside the Ministry of Health. So you can notice the change in the language when you go to the different entities, even outside the healthcare sector. When it comes to Ministry of Finance, other governmental entity, the discussion has changed. I thought being part of the Payor, and we did not imagine that 5 years ago, Prof. Hussam will go with the Payor and I will go with the provider. And I thought part of me as a provider, just to give just one slide for the team, especially for the international speaker, to just share with them the landscape of the provider space. How does it organized? So based on what Professor Hussam mentioned around how to create value, how to integrate care, how to promote the integrated care pathway, and promote the care coordination, and make sure we increase the accountability. We divided the country into 21 cluster or region area, and every area will be responsible for its population. They will have their own defined population, and this cluster will be accountable for the care for the population, accountable for the health, accountable for the cost of that, of the delivering of that health and organization. And to achieve that, it's a long journey that require the support from all of us in the coming few years. And it requires us to take a role in this, to have a whole system approach, how to embrace a population health management, how to embrace the new way of delivering the care. And I think the question for us all today is, how are you going to support the BHM agenda, how to make sure it's integrated in every part of our cluster, in our system, and the thinking of the doctors and nurses and the as a frontliners. I don't want to take longer than this. My hope for today, it's that it's a day of discovery, a day of learning, exploration, and to work together to find a way and to find the best plan forward together as a team. Thank you so much again, and hopefully you will have a great day today. Thank you so much.
So thank you very much, Dr. AlFaleh Alqahtani, for this introduction, and particularly for the interesting stimuli that you bring to our attention. Now, I would like to briefly show you all the speakers that we have today, but I will introduce them one by one before their speech. Now, just to give you some also additional information regarding the final aim of this workshop. So at the end of this workshop, we would like to build consensus statement, and a final perspective in brief will be shared among participants. I also would like to ask to the speakers to share with us all the materials that they will present today. And another communication for the participants is that at the end of this workshop, we will receive, you will receive the certificate of attendance. Now we can start with this first section of this workshop. So the priority setting in healthcare systems from the payer perspective. The first speaker is Dr. Khoja. The title of his presentation is "The Pulse of Value-Based Care, Kingdom of Saudi Arabia, a Population Health Management Framework." So Dr. Khoja, please, the floor is yours.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, everyone. So if you can allow me to share the screen. Yes, great. Okay, great. Sabah al-khair, everyone. Good morning, everyone. So today I'm going to speak on and discuss with you how in Saudi Arabia we are going to use, or we are planning to use, the population health management as a way to pursue the value-based healthcare and attaining the quadruple aim of the health care system. In Saudi Arabia, that we are going and undergoes a tremendous and large-scale transformation or reform in the healthcare system. This reform did not happen in isolation. It is associated with a wide reform and transformation across different sectors, and that's really very useful, as all of you believe and know that the transformation or the impact of social change and other social determinants of health on the health outcomes. So that's help us moving forward with that transformation, and we should keep that in our account when we talk about the vision of the transformation in healthcare system. King Salman, the custodian of Holy Mosque, and his crown prince, they started and launched the 2030 vision. The 2030 vision really concentrates on three main themes, and it's basically the society, the human, the economy, and dealing with building an ambitious nation. And that really speaks to the definition of health. Health is not, as we all know, it's not only the absence of the disease, it's the status of wellness that include physical, mental, and social well-being. So then the overall transformation that is happening in the Kingdom of Saudi Arabia, for sure it will impact the health outcomes, as we have in our 2030 vision goal of increasing the life expectancy from 74 to 80 years, and build on our strength and try to work on the opportunities in the kingdom in order to be a leading country and society. That wouldn't happen without, for sure, a healthy individual. And that's why we are moving toward the transformation, large-scale transformation in the health sector in Saudi Arabia. The transformation in the health sector take into account the value-based approach as a direction, and trying to address the access of care, addressing the public health threats, and also dealing with high area of burden, like, for example, road safety and so on and so forth. And all of that is aligned with the national transformation goals and 2030 vision. In Saudi Arabia, as we are going through the transformation, the value-based healthcare was put as the true north for the transformation. The value-based healthcare focus on attaining the triple aim or a quadruple aim, and that basically speaks to the improving the population health, the people in the clusters, in the neighborhood, in our catchment area, in the country at large. And delivering a better care that addresses the quality of care, safety, experience, and satisfaction, and build a responsive system to the need and the value of our population. And that's very critical when we are talking about population health management and how we are going to set the priority by introducing the perspective of the individual in our priority settings matrix. For sure, as Dr. Hussam and Dr. Abdulrahman mentioned, we are concerned about the rising burden of the economic burden of healthcare system and disease. And that's basically due to the high prevalence of multi-chronic disease, chronic condition in a young population. So we are trying to reduce or contain the cost of the health system and to assure the financial protection for the individuals and the people and disadvantaged population, and also to assure the sustainability of the healthcare system. That wouldn't happen, the transformation wouldn't happen unless we also assure the well-being of our healthcare professionals, and assuring the readiness of the system, especially with our experience currently with the recent experience with Corona and COVID-19. So that's put this on the agenda of all healthcare systems. So we have to think about how we are going to build and assure the wellness and empowering and assuring the availability of the capability in our system in order to attain the other aims while we are doing this large-scale transformation. Based on that, Saudi Arabia, Dr. Hussam and Dr. Abdulrahman, they mentioned that there are a lot of initiatives came out of the transformation, and one of these initiatives is trying to assure the accountability are set in a way that induce and promote the outcome that we care about. That's why the program for health assurance, which would be the National Insurance Center, will establish clear accountability and increased provider accountability is one of the main outcomes of this transformation, and moving forward toward the value-based healthcare and using the population health management as a way to bridge the current gap between different stakeholders, within the system, the healthcare system, and outside the healthcare system, in order to move forward and push the system to attain the quadruple aim. Based on our understanding of evidence and experience worldwide, we found that in order to move forward with the value-based healthcare agenda, we have to continuously measure the outcomes and the cost, and deal with our population in the segments, and assess the cost and outcome related to these segments, and develop and deploy a segment-specific intervention.
Dr. Khoja, sorry
Yes.
for interrupting you, but we cannot see the presentation moving on. So I don't know if it is a problem or if it is by your choice, but just to let you know.
Oh,
that
sorry.
we are still seeing the first slide.
Oh, interesting. Okay.
Sorry for having interrupted.
Yes. Okay. Sure. Okay.
Thank you.
Okay, you inform me. Okay. That anyway. So here are the quadruple aim of the healthcare system that address the aim of our transformation. As I mentioned, we learn from different experience from different countries and from different healthcare systems. That's why we elect to move our transformation in a way that create the right foundation for population health management. We try to move our design to manage the health at the scale of the population and population segments. And also, while we are doing that, we need to establish a learning system, data-driven, in order to assure the sustainability and continuous learning from our experience and inputs. We believe that population health management will be work as the ethos for how the health system should work. It will help in bridging the gap between the healthcare delivery, the traditional way, the healthcare delivery in a traditional way, and the public health concepts, and understanding the population and determination, social determinants of health. So our understanding or definitions for population health management, we adopted these definitions, and we believe that population health management is a comprehensive framework that deal with designing, delivering, and coordinating the service, and also the payment in order to manage the quadruple aim. For sure, that means that population health management deals with a large-scale transformation. It utilizes best available resources, data, intelligence, and trying to push the system to have a different kind of integration, horizontal and vertical integration between different players within the healthcare system, and also player outside the healthcare system, in order to move from segregated healthcare delivery to a population health system that address the social need and social care and the community and population values. Dr. Hussam and Dr. Abdulrahman, they mentioned that we introduced this population health management to deal with many issues related to the patient experience, the segregation of care, and for sure also the experience of the providers, the healthcare worker, and empowering all the stakeholders with the intelligence and decisions in order to respond to the need of our population. We believe that population health management is not a theory. It's not an academic approach or academic discussion. It's a set of intervention that we need to think about, we need to implement and assess and improve in an agile way. That's why we developed this, our national framework for population health management. Our national framework for population health management, or Saudi population health management framework, try to address different issues. And it was built in a collaborative work between different sectors in order to respond to the current context of health system design, the current system design, and how we can move and push the system to the limit that help everyone to work and to address the agenda of value-based healthcare. At the heart of our framework is the quadruple aim. It's improving population health, containing the cost, improving the experience and better care, and the wellness of our healthcare provider and the readiness of the healthcare system. The framework starts basically with identifying our population. And when we are talking about identifying our population, we need to know who are our population, where they live. What is the catchment area? What's the count? And then we try to establish and answer a very critical question related to accountability. Accountability to the funding scheme. Who will pay for those people or these segments? Accountability to healthcare provider, and we call that assignment. So we want to assign every individual in the country to a healthcare cluster. And the third question is attribution, and we are trying to introduce in Saudi Arabia the concept of team-based care to enhance the primary health care. So we want to attribute each individual to a team-based or to a primary healthcare center, and to that, all of that will help us to establish the accountability and to know better our population, who will pay for them, who will take care of them, how we can set the accountabilities and assess the outcomes and the performance. The second, that's the basics for our framework. The first step in our framework is to understand the need of our population. Unfortunately, we have challenges currently in the infrastructure related to the data, and that's why we came up with a different approach, innovative approach to understand better our population needs. And that's basically when we say population need, we are trying to address the distribution of health outcomes, prevalence of disease, the supply, the performance, the current performance of the system, and how we can utilize all of these ideas or this data and this point and these insights in a way to inform our priority settings and segmenting our population. And for that reason, we start thinking about using the summary measure for public health or for population health management. How we can utilize these as an input to set the priority. In value-based healthcare, people, they are thinking about PROMs and outcome measure, which is things that you assess after the fact. Yeah, you design it in the front, up front, but you measure it after the introduction of the intervention. How can we introduce the perceptions and the value of our population in setting the priority by using a complex summary measure like DALYs and QALYs and other method responding to the value of our population, such as, for example, the burden of disease of one condition. How can we introduce the right weight that respond to the ethical and the cultural norms in the Kingdom of Saudi Arabia? So that's basically one of the main essence that we want to introduce the need and to introduce, to build the system in a way that help it to be responsive to the value at the design and the priority setting phase. The second level, after we do our health need assessment and setting the priority by using the different approaches and data points that can be national surveys, it can be primary healthcare data, and we are really emphasizing on developing the infrastructure for IT, connecting different dots, utilization, administrative data, and prescription data in order to really understand our needs using a global approach for health need assessment. That will be followed with segmentation, and the idea of our way of segmentation to have a segmentation model that responds to the model of care in order to facilitate deploying the right intervention to each segment of the population based on their need. Prioritization of the intervention is the second domain in our framework. We want to introduce the idea of impact assessment and potential assessment, feasibility assessment when we make any decisions, and how we can assess and plan in advance different data points to be collected in order to assure that we are building a learning system over time. Then we are talking about the intervention. Intervention, it can be a policy development, it can be a pathway improvement. There is a wide variety of intervention that can be introduced by understanding the need and the gaps and the performance of the systems and the supply. And that's basically what is the model of care trying to achieve in the Kingdom of Saudi Arabia. And follow that, we evaluate the impact, and that it's a continuous activity in order to move forward as a learning system. The framework really we believe it can be applied at the micro level of the health system, meso and macro. This idea is to push them the system of the healthcare system toward a population health system. In order to implement the population health management, yes, it's a complex approach. It's a new approach. There is a lot of experience in some of the areas. However, we understand that we need to develop and be humble enough to learn from our mistake, to learn from different experiences based on the current context. That's why we believe that there is a critical drivers for population health management, which are having a clear vision and realization and alignment between different stakeholders with clear governance, right culture of trust, collaboration and integration, activation of our population and involving them from the beginning, from setting the priorities, adjusting for these priorities, how it's calculated, dealing with the ethical and scientific and methodological issues at priori, and then involving them in designing different intervention in an agile way. And for sure, primary healthcare is a cornerstone of this intervention related to population health management. We need to move as an agile in order to be a learning system. For sure, there is a lot of enablers that the current system is working to develop, which are building the capability, for example, to deliver the model of care capacity and capability of leadership in the system, and new competencies related to population health analytics, integration, system thinking, and so on and so forth. The infrastructure, I mentioned the infrastructure related to the IT and data strategy. Standardization is very critical. Standardization of care, standardization of the analysis, standardization of how the outcomes should be measured, and developing standard policies. And for sure, it's a primary activities of our population health management, starting from population identification, health need assessment, impact assessment, financial incentives, using the financial and the funding and the purchasing as a lever for the system to move forward in order to attain the quadruple aim. In this particular workshop that we are having today, we want to discuss really how we should use the summary measure of population health management, the summary measure of population health to inform the value-based healthcare. We propose that using the summary measure will help us to understand the national disease burden in a way that it responds to population need. It will include an account for population perspective in understanding the need and understanding the disease burden. It will help us in collecting the right data in a standardized way and develop a national adjustment or weights to respond to the population preference and context, and also it will help utilization of the current data to inform. It will help us, the current today discussion will help us to understand how can we utilize the available data to inform the burden of disease calculation. Utilizing the measure, the summary measures, it's used widely to inform policy settings, priority settings, planning, and also we are aiming to use it to assess in the future and currently the impact of large-scale interventions such as model of care and incentives and so on and so forth. And all of that will help us to attain and moving the value-based healthcare agenda. As all of you know, using the summary measure, it's a little bit challenging because of the problem related to the ethical choices, the validity of utilizing this. So we want to know more, how can we adjust for this methodological design using different data source, how we develop the adjustment and use the assumptions, how can we address the need of disadvantaged group and population, and how we can also use the summary measure in policy development across all domains of population health management. Thank you very much for the time, and looking forward for the engagement and learning from your experience. Thank you.
Thank you very much, Dr. Khoja, for your presentation, for your very excellent overview. And I would like to invite all the participants, if there are any questions, to write them in the chat, so we can try to reply to them immediately after the speech. I would like also now to remind to all the speakers to be on time in order to respect the timeline of the agenda, to take approximately 15 minutes for each oral presentation in order to give also time for the questions and answer. Now it's my pleasure to introduce to you my mentor, Professor Carlo Signorelli. He is a full professor in public health at Vita Salute San Raffaele University. He is director of postgraduate school in hygiene and preventive medicine, and past president of the Italian Society of Hygiene, Preventive Medicine and Public Health, and treasurer of the European Public Health Association. He was also a consultant for the Ministry of Health on the Italian National Immunization and Prevention Plan. And the title of his presentation is The Use of Summary Measures of Population Health for Priority Setting. Please, Professor Signorelli, the floor is yours.
Thank you very much, Professor Gianfredi. I think there is a sort of problem in my screen in order to show my slide, and I'm quite sure you are not see my slide at the moment. Is it correct?
Yes, indeed, we can't see your presentation.
There is a sort of technical problem. I don't know how to manage it. I don't know how to do it. probably a problem with the computer, and I ask maybe the moderator if we can move on to the next speaker, David Hunter, in order to, to solve the technical problem, unless you can show my slide.
I think, Professor Signorelli, that I can share your screen,
yeah.
The presentation using my screen, if it is fine with you.
Yes, please.
Okay, so just 1 minute. I need to ask to Professor Hunter to interrupt the sharing.
If you want, sorry for the technical problem, maybe it's better if Professor Hunter is ready, and we will solve the problem in a short time.
Okay, so
sorry about this.
Okay, so I will move to present Professor David Hunter. Professor David Hunter, since August 2018, is Emeritus Professor of Health Policy and Management at the Newcastle University in the Population Health Sciences Institute. He is a visiting professor at the University of Chester, and he is also a special advisor for the WHO Europe on the health system transformation, and since July 2020, a member of the WHO's Global Network on Long-Term Care. Lastly, he is an honorary member of the UK Faculty of Public Health and Fellow of the Royal College of Physicians in Edinburgh. The title of his presentation is The Triple Aim Agenda, the Payor Perspective in Setting Population Health Priorities. Professor Hunter, the floor is yours, please.
Good morning. Thank you very much. I think I'm having the same technical problem in being unable to share my screen as the previous speaker. I don't know why.
Now
it says screen sharing, but
now we are seeing your screen. The web page on the Zoom platform. So, and now also your folders.
Okay, well, let me see if I can find here we are. See if this one's working. Right.
Now also the presentation.
Okay.
Maybe if you can put it in the presentation mode, it will
I'm trying to
be
do
better.
that. Yeah.
Or at least if you can make it bigger in full screen or something.
Yeah,
like
I'm trying to do that now.
The bottom, I think, is in the.
Here we are. Yeah.
Yes, exactly. At the end on the right.
No.
No. The previous one.
Yeah. Now, hang on. Look at that one fit to. No, it's not doing it either. Hang on. How can I get this onto a big screen? Fit to one.
Maybe is read more or what?
Better?
No.
No. Oh, I don't know why it's doing this.
No, maybe I think it's the bottom read more. I'm not sure about, but you can try with that.
Sorry, Professor, can you please press F11?
F11?
Yes, with with this, press F11.
Hang on. Right. I'm pressing F11.
No, it's not changing anything, so. Press the square close to the X at the top of the page of the window.
Here?
No, top right.
Top right. There.
Yeah, no, that's left. Top right.
Oh, sorry. Top right.
Yeah, no.
But from the presentation,
yes,
from the file of the presentation,
of the PDF.
Close to X.
Um,
really on the top.
This one here?
No, upper just upper in the right corner, where you have the X to close the file. Close to that, you have the square. Try to close. Try to click on it.
This one?
No.
So,
upper, really on the top.
On the very top.
Yes, exactly.
Remote.
Upper.
And more.
Yes. No, because now you are outside the
right.
file. Okay, so if you can see on these windows, you have the title of your presentation, workshop, PH, aim, and blah, blah, blah.
Yeah.
That it is on the left. If you go extremely on the right, you have the square and the X. Click on the square, close to the X.
Oh, here.
Yes, exactly. Yes.
Right. It was hidden before. I couldn't get access to it. Is that better?
More or less. Maybe you can click on the other symbols close to 100% on the Windows tool.
Professor, can you, they're suggesting press Control and L.
L?
Yes, Control
Right.
L together.
All right. Yeah, I've done that.
Nothing happens.
Just come back. I don't know why it's not letting me show my slides. Add slides. I mean,
or maybe try to reduce the zoom instead of 100%, reduce it at 60% or 70%.
Yeah, hang on.
Something like that.
Yeah, here we are. If I do 75, is that better? Or 50? Is that better?
Yes, now we can see the full slide.
Okay.
I think that it is the best way to proceed. Thank you.
That's the way, yeah, I'll do that. Sorry about that. Sorry about the delay. Okay, I'll not go on longer than my allotted time. This presentation is a little bit different from some of the others because it's setting the overall challenges facing health system reform in many countries, and obviously Saudi Arabia is well ahead of some countries, but also meeting some of the challenges that are confronting other systems. The presentation draws on insights from our WHO Europe Health System Transformation Project, co-led by myself and my colleague Rafael Bengoa from Bilbao, Spain. Rafael is a former Minister of Health in Spain, and before that was WHO Director for Non-Communicable Diseases in Geneva. And we ran this project from 2015 till 2020, looking at various healthcare systems in Europe in terms of the challenges they were facing, which mirror those that are being confronted in Saudi Arabia. And it seems to me that these insights are important because whatever summary measures of population health we choose to employ and use in our healthcare systems, as was described in the last presentation, these will only work if policy is made to stick and if implementation failure is avoided. And what's become quite apparent from the evidence is that many countries embark upon change and find it difficult to make the policy stick and encounter implementation failure. And our WHO project was an attempt to see why that was happening and what lessons there might be to learn from that. So just think of a very, seem to have lost a slide. I was going to give a very brief definition of health system transformation drawn from a Canadian group, written up in the Millbank Quarterly some years ago, and they defined large-scale transformations in healthcare as interventions aimed at coordinated system-wide change affecting multiple organizations and care providers, with the goal of significant improvements in the efficiency of healthcare delivery, the quality of patient care, and population-level patient outcomes, all of which comes together in the triple aim. But these are really complex challenges that face healthcare systems, much more complex than challenges that have faced healthcare systems in previous eras. As we've said, even the triple aim now is being overtaken by the quadruple aim, where the healthcare workforce is an important element of any health system change process. So the challenges facing healthcare systems globally are incredibly complex, much more so than in earlier eras. And if we go to the last bullet point on that slide, 2000 going forward, we're in the midst of what we've been hearing about in regard to equitable health improvement, talking about health development over the life course, from birth through to a good death, rebalancing acute care and prevention, so we give far more focus to health promotion and prevention and health improvement than simply taking people into hospital and caring for them there. And we are increasingly trying to engage individuals, communities, the public as co-designers of their health, so they become key stakeholders in improving their health status. So if we look around Europe and beyond, healthcare systems everywhere are looking to be more proactive and preventive in their healthcare arrangements, giving better management of chronic conditions, much more of a focus on quality, more patient and public engagement, focusing, as we've said, on population health management, tackling health inequalities, using information and communication technology as appropriate, and moving towards outcome-based payment models to encourage value as opposed to activity. Now, arguably, the pandemic, COVID-19, has made many of these issues much more important, and countries that might have been slow to make progress in these areas are realizing that COVID has exposed their populations to key public health issues and key concerns around inequality that were arguably evident prior to the pandemic, but have become much more acute since the pandemic has impacted on population health. So arguably, the pandemic could provide a burning platform, a policy window, to bring about real change and shifting the balance of care towards population health and away from a downstream repair and cure model of care. Well, there's a definition that I had for some reason. So our work in the WHO project was about not the why or what of change, because I think we all know what the problems are and why we have to do something about them, but we were focusing on the how question. How do we bring about change in complex health systems when in the past it's been difficult, although arguably the challenges have been easier to contend with. And we started off by looking at what was perhaps necessary to put in place, which was a receptive context for change. So unless there was a receptive context for change in existence, it would be very difficult to secure effective policy implementation. And we devised a framework made up of 5 key factors: environmental pressure, quality and coherence of policy, key people leading change, a supportive organizational culture, and good, well-developed managerial clinical relations. I say clinical, I mean all healthcare professions, but among the healthcare professions, the key profession remains the clinical profession, and therefore they have to be on board with many of the changes that are taking place. I won't go through each of these in detail, but environmental pressure really refers to the overall context in which change is taking place in a country or a healthcare system. And that might include the political context, it might include the nature of the environment in terms of the issues we're trying to confront, like, for example, the pandemic and the impact of COVID-19. That's a key environmental pressure affecting all healthcare systems now. So the environmental context is really important in order to secure support for the policy change that one's trying to bring about. Then within that, the policy design, the quality and coherence of policy needs to be in place if that policy is going to have any chance of success. And I'll come back to that a bit later. Leadership was mentioned in the last presentation, and that really is important, and I'll come back to that. But the style of leadership, the kind of capacities and skills leaders need to have to work in an integrated health system context are really important, and arguably we haven't given enough attention to the kinds of leadership styles that are necessary to bring about real change in healthcare systems. And that means looking across the whole healthcare system, primary, secondary, public health, and also social care in terms of the whole system impact of health. And of course, much of what contributes to health lies outside the healthcare system in regard to things like housing, transport, education, the nature of work, and so on. So it's multi-sectoral as well as affecting the healthcare system itself. Organizational culture. Health systems comprise a set of multiple cultures or tribes or different professional groups. Often change in healthcare systems focuses on structural change, but arguably organizational change will not occur successfully unless cultural change is undertaken and given adequate attention. And then finally, the issue of managerial clinical relations. Unless there is real engagement by clinicians and other professions in the change process that's underway, then change is unlikely to occur. It can be blocked, it can be sabotaged, it can be derailed in regard to it ever really happening. Now, using the framework, these factors are not a shopping list. The 5 factors are interrelated. They should be taken together. If they're taken together, they can guide and shape transformational change efforts. Successful change requires good alignment among these 5 factors, because if they push and pull in different directions, if the policy itself is confused and trying to do different things that conflict with each other, then change will be difficult to sustain, and success is unlikely. Even then, there can be no guarantees, because as we all know, there's no simple recipe or quick fix in managing complex change. And I'll develop that a little bit in the next few slides, and then hopefully bring this to a conclusion. So what are the explanations for policy failure? Well, overly optimistic expectations. We can sometimes expect too much from policy that's not going to be possible to realize. Implementation and dispersed governance. We heard in the last presentation about the micro, the meso, the macro levels in decision-making and policy-making. And if there's disconnect between these different levels, particularly between the national and the local level, then it makes governance and the achievement of policy change very difficult. Inadequate collaborative policymaking, again, in a whole healthcare system, you're talking about a lot of collaboration between different groups and different organizational components. And much of healthcare is still delivered in silos where there is no good collaboration and very little connection between the different elements. And that needs to be ensured if we're going to get whole system change. The political cycle can make an impact. We all know that complex change takes time to take place, to be sustained. It needs time to be given to allow that change to become embedded. Short-term political cycles make that difficult sometimes. So we need to be attentive, I think, to the vagaries of the political cycle. And then finally, often policymaking focuses on the front end, the agenda setting, the formulation of policy end, and doesn't give sufficient attention to implementation. And implementation is therefore often neglected or weak as a result. So what are some of the reasons for implementation failure? Well, absence of buy-in, ownership from professional staff, notably clinicians, too much change, big bang change, huge change that's not sustained, and as a result, little change occurs because politicians change or different fashions change, and that momentum that's initially launched doesn't get sustained over time. Resource cuts, austerity, cost cutting, so investment in change is lacking or insufficient. Change does require transformational funds to make it happen. Weak or undeveloped capacity to manage change and effect change. Staff suffering from reform fatigue, burnout, which is a result of too much change happening too quickly. That can result in disengagement and a loss of interest and a lack of commitment to that change. Often we lose the people who are driving change in local organizations through promotion or through their departure. We have to be attentive to the whole issue of leadership, sustainability, and making sure the right people are in place at the right time. Political realities, which can divert energy and derail change for the reasons I've said in terms of short-term thinking, when in fact we need long-term sustained thinking to bring about real change. And perception of change is simply technical change. So if we have the right data, the right methods, the right measures of population health, then change will happen. Whereas in fact, change is more about adaptation, about context, and about the softer skills, if you like, of relationship building and culture change. And we need to attend to these alongside the more hard-nosed and technical data-led tools. So just a couple of final slides. The risks of health service transformation are hard. It's hard work to do to successfully bring about. Change can be too fast, have weak ownership, as I've said, unrealistic expectations. There might be a skills deficit in change management. The requisite leadership style is missing, reform fatigue, as I've said, and too much focus on structures, not enough on changing the cultures. So those would be the summary points in terms of the risks attached to health system transformation. If we want it to succeed, we have to look at these issues and take them on board seriously. So what are some of the key ingredients for success? This is my last slide. Well, we need to create strategic alignment. Obviously, there needs to be a vision, because without a vision, there's no alignment and no change. But the vision on its own is not going to be enough. So we have to look at the connections between the whys and the whats and the hows of change. And arguably, as I said at the outset, we focus very much on the whys and whats of change, but not on the hows, not how to bring it about and how to sustain it and embed it over time. Change is probably most likely to succeed if it's co-produced with professional cultures, less top-down, more bottom-up, more engagement from people on the front line who are actually delivering care. Relationship building is critical at all levels of governance, both horizontally and vertically. We need to make sure the right leadership styles are in place. Whole system leadership, distributed leadership are quite different styles of leadership from running a hospital, for example, or running a primary care clinic. So we need to make sure those whole system approaches that cross boundaries professionally and organizationally are in place. And arguably, there's something to be said about being tight about ends and loose about means. And I mean by that, tight about what we're trying to achieve by way of outcomes, but loose about the way of getting there, allowing people to experiment, try different things, monitor what they're doing, hold them to account to the outcomes we want to achieve, but how they achieve those outcomes might be varied in different local contexts. Arguably, I would say healthcare systems have traditionally been much more tight about means and loose about ends, and we need to reverse that, I think. We need to base our decisions on good evidence-informed policy and make sure we bring that research to bear on developments in relation to what we're trying to achieve and how we might achieve it. And we need to make sure we have a cadre of experienced change managers who are able to implement and bring about real change, possibly with support, with implementation support programs and other mechanisms in place to assist and support them. So those would be my key ingredients for success that have come out of our WHO health system transformation work. And I think these need to be almost a prerequisite before thinking about how we engage with summary measures of population health. Important though they are, the context in which we're adopting those measures needs to be in place before those measures are likely to be successful. So thank you for that presentation. I'm sorry about the technical problems at the beginning.
Thank you very much, Professor Hunter. I didn't receive any questions from the participant. I would like to invite you to write all the questions in the questions and answers section or even in the chat. Otherwise, we can also discuss later on during the roundtable. Now it is the turn of Professor Signorelli, I think, and I hope that you solved the issues with your presentation. Yes, we can see actually your presentation. So please, Professor Signorelli, the floor is yours. Professor Signorelli, you are mute, so please switch on the microphone.
Okay, can you hear me?
Yes, now we can. And also we can see your presentation.
Thank you very much indeed. Sorry for all the technical problems. And I hope now everything is fine and I can give you this presentation That's mainly a technical presentation trying to explain the use of summary measures of population health for priority setting and a little bit about discussing the demographic and epidemiological transition, showing some data concerning Saudi Arabia. We start with some definition, very simple definition. Population health can be defined by the health outcomes and their distribution in a population or in a group of individuals, while summary measure of population health are epidemiological metrics that combine information on mortality, but also information on non-fatal health outcomes in a single numerical index. When we discuss about burden of disease, we refer to the impact of predefined health problem in a group of people or in a population. Trying to explain what is a demographic transition. The demographic transition that happens in most countries, it takes some years, probably some decades, and it's moving from a picture of high natality and high mortality. So during the transition, there is a decrease of natality and mortality, and consequently an increase of life expectancy. And this is what's going to happen in many GCC countries, including Saudi Arabia, where we can see in this graph that the 5 year, under 5 year and under 1 year, so the infant mortality change and decrease quite a lot starting at 1990, so in the past 30 years. Going down from 35 and 45 per thousand, close to 5 per thousand. And also the total fertility rate that's going down from 6.5 of the 90s to 1.7, and the projections from 2020 to the end of the century is a stable trend of total fertility rate in Saudi Arabia. And this is a change of the age structure of the population in Saudi Arabia. The gray pyramid is showing the 99 picture. The blue one is the current pyramid with a decrease in natality and an age, average age of the population that is still low. But in the orange picture, we see what's going to happen, on what we think we can happen in the next 80 years. And is a population age structure which will be very similar to the current European and North American distribution. In parallel with the demographic transition, we can see the epidemiological transition. That is a process beginning when infectious diseases were predominant and ending where non-communicable diseases, the NCDs, dominated the causes of deaths. And of course, this will result in a change in health needs. So why we are using the summary measures to provide appropriate attention to the non-fatal health outcomes, in particular the chronic diseases, to monitor and compare the health of one or more population and subpopulation, to identify and quantify the overall health inequalities, to support decision making, to improve health planning, and to guide research and development. We have two groups of summary measures of population health, those concerning health expectancies and those considering health gaps. In particular, one of the most used summary measure is the disability adjusted life years that was introduced about 30 years ago in alternative to the life expectation. And we can see in this picture the lower curve is the life expectancy, and the bold one is the life expectancy in full health. So the difference is related to the health gaps summary measures. The daily disability adjusted life years is one of the most common summary measure used, as I told you before, and we consider the years of life lost plus the years lived with some disability, and there are questionnaire and standard guidelines to define these characteristics of the individual. What we generally do is to consider demographic data and epidemiological data in order to find out summary measure of the population health. With the summary measures of the population health, we can better develop health policies, as said in the introduction of this meeting. There is a problem that I'd like to underline in this technical presentation, that if we have lack of epidemiological data, in particular, I mean, generally demographic data are available and of good quality everywhere, but epidemiological data not all the time are reliable, and that is problem. So we need data, but we need also high quality data. Otherwise, we have no results, and consequently, we are not able to recognize in a good way health need and consider them for a proper health policy. And that is a problem. And we know that one of the points to improve is to collect high quality data, high quality epidemiological data, in particular data on risk factors, because we are able with data on risk factor to predict the trend of chronic disease in the future, and consequently also to define health needs in the next decades. The methods for calculating summary measure can be influenced by the technique and by the weighting for age and time of the health intervention. So there are different variables that are able to influence the summary measures. The problem is well known from WHO and other international organizations that in 1993, many years ago, they start with studies in all over the world, so WHO and World Bank, to study daily and other summary measures in order to fix the global burden of disease. And there are a lot of publications considering this, supported by World Health Organization and conducted by the Institute for Health Metrics and Evaluation that publish yearly updates about the global burden of disease that contributes to have an overall picture of the situation and the evolution of all the causes of disease in the world. In particular, the last publication, the Global Burden of Disease Study of 2019, is dealing with 369 diseases and injuries, 87 risk factors, considering 204 countries or territories in the world. And we have a lot of data to predict the future and to predict the health needs in the different populations. This is the burden of disease in Europe from 90s until now. And we see that, we notice that there are some changes, but basically the two main causes of daily still remain cardiovascular disease and cancer, while there is an increase of musculoskeletal disorders due also to the increase of age and neurological disorders and also diabetes, with a decrease of injuries due to the activities of prevention on that. The daily in different countries, in the picture we see the GCC countries, but also other Asian countries. There was the Afghanistan and Pakistan, while Saudi Arabia, as you see in the map, is on average. And so we start from a daily, which is not the worst of the area. I would say probably is one of the best of the area. And we see how the burden of disease changed in the past 30 years. With a decrease of neonatal preterm birth and all related with that. It remained the second cause of daily, the motor vehicle road injuries. That's still a problem. And an increase, you can see, of some causes and some diseases, including ischemic heart diseases and some neurological and cardiovascular disease. Not very common, the incidence of cancer due to the low average age of the population, but I'm sure that in the next years, due to the increase of the median age of the population, there is also the problem to manage with cancer. Diabetes and cardiovascular disease in Saudi Arabia are increasing, still not so much due to the age distribution, but as you can see in this projection, the number of cases will more than double by 2035. We can see also the distribution of the risk factors for cardiovascular disease. Unfortunately, there is increase of risk factors, and what is my message is also to look at primary prevention in order to reduce the risk factor and improve health, well, lifestyle in the population. We see the common risk factor for the cardiovascular disease. For road injuries, we still need prevention activities, not only from the health service, but certainly for infrastructure intervention in order to improve road safety and reduce the total number of car accidents that are quite important. The number is high, but not only car accidents, also work injuries that are quite common, much higher than European and North American countries at the moment. We are moving to the end of this presentation, trying to summarize the use of a summary measure to monitor the health status of the population and give suggestion for health needs and health priority setting and policy making. So summary measure provide directly evidence to monitor the size of burden of disease, to improve population health, and to deliver cost-effective intervention or value-based healthcare as defined in the introduction. Priority setting and resources allocation in health sector are also influenced by economic assessment, political will, public support, professional support, workforce, ethical consideration, pressure from lobbies, and also local interest. So it's a quite difficult job conducted by a politician. I'd like to leave some final remarks and take-home messages from my technical and epidemiological presentation. We confirm that GCC countries are in a rapid demographic and epidemiological transition. I would say more rapid demographic than the epidemiological transition, but we will see in the next decades population aging, increase of non-communicable disease, and of course changing health needs. Only with tailored and efficient health system based on hospitals, but also primary care, primary healthcare services, it will be possible to provide value-based performances to contain simultaneously the cost. Health policies must be accompanied by effective primary and secondary prevention, which include the vaccination, mainly for infectious disease, but not only for infectious disease, as you certainly know that vaccination against B hepatitis and papillomavirus are able to prevent chronic conditions and cancer. We would like to stress the importance to improve actions of health educations, also to use better the health services and screening programs, both for cardiovascular disease, diabetes, and cancer. And finally, sorry for this change, the switch of the presentation, but we have also to consider what was mentioned before, that standardized measure could inform all the steps of population health management to sustain strategic purchasing from the health needs assessment and the impact evaluation to attain the triple aim of healthcare that was previously described. At the end, I'd like to thank very much for having invited me and having involved my research team in this very interesting seminar, but also like to congratulate with the Saudi Arabia authorities for the attention they play to set a high standard health system for the next generation and for the next future. Thank you very much.
Thank you very much, Professor Signorelli. We also receive in chat some thankful messages for your presentation and congratulations for the good quality of the presentation and the scientific value of it. We have also a request from one of the participants, Dr. Sally Ansari. If he is here, please, the floor is yours, but please do not spend more than 5 minutes in total for answer and question. He is still here with us?
Yes. Do you hear me? Yes.
Yes, we can.
Yes. Thank you very much. Very interesting papers. And I have very short question. How does this population health go with privatization? We used to go in the future toward purchasing healthcare, medical care from the private sector. How about population health? How are we going to, or we are taking care of it within the system? And if we are doing the privatization, who will be the one to take care of the population health, where clinical issues cannot be separated from preventive issues? Thank you.
Professor Signorelli, I think that you can maybe
yes. Can you hear me?
Yes.
Yes. I don't know if the question is for me or for other speakers, but what I can say, and I use the Italian example to describe that we have in Italy a public national health service, but we have public and private providers. It means that 1/3 of Italian performances delivered by hospital are delivered by private accredited hospitals. It means that I mean, the people, they don't pay, and the National Health Service is paying for that performance. This happens for the hospital care, but also for laboratories, diagnostic. So the issue is a political issue, but the example of Italy is quite clear that it's possible to deliver a good healthcare from the state using private and private providers. It's a political decision. It's not a technical decision, but certainly the example of Italy is quite clear. We are probably one of the best and renowned public health system in the world, with a private hospital that work mainly for the National Health Service.
Thank you very much, Professor Signorelli, for the clarification and the answer. We can now close this first session of the meeting and move to the second one, where we will speak about the national and international experiences of core summary measures of population health. It is now the turn of Professor Seok Jun Yoon, He is a health policy and health promotion professor of the Department of Preventive Medicine at the College of Medicine and Dean of the Graduate School of Public Health at the Korea University of Seoul in the Republic of Korea. He was also part of the development of the National Disability Weights for the Republic of Korea. And the title of his presentation is A Case Study from South Korea, an Independent National Burden of Disease in a National Health Insurance-Based Healthcare System. Professor Hyuna, the floor is yours, please.
Nice to meet you. I'm Dr. Yoon from South Korea. Can you hear my sound clearly or loudly?
Yes. We can, yes?
Yeah, okay. I'll present a case study from South Korea on independent national burden of disease in a national health insurance-based healthcare system. I have three contents. First one is history of KMBD study. KMBD means Korean National Burden of Disease study. Second one is our method. And third one is result and challenges. Firstly, history of KMBD study. We started this burden of disease study in South Korea from 2002. At that time, our project title is estimating the burden of approximately 130 diseases. And then in 2007, we study another methodology and economic burden of major disease. And in 2012, we got a big grant from Ministry of Health and Welfare of South Korea government. So we studied a study on measuring and forecasting the burden of disease in Korea. We started at that time, and in 2016, at that time, we got another big grant from our government. At that time, we mainly focused to hair, to measure hair. So our target increase in the target disease since 2002 from 130 to nowadays 260, and we modified the methodology for considering the Korean specific context. Mainly, we have big data from National Health Insurance Service System, and we recalculated the disability weight. In 2012, at the time, our project title is Korean National Burden of Disease Study, initiated by the Research and Development Project of the Ministry of Health and Welfare, funded by a 5-year grant from 2013 to 2018. At that time, we got research grant to $2.1 million over 5 years from our government. And then we got another big grant from our government from 2018 for 3 years. At the time, our studies focused on health adjusted life expectancy, HAIL study. We got at the time a research grant from our government, 1.6 million over 3 years from our government. Our study, our KMBD study, slightly different from GBD study. Originally, I know GBD study, data from GBD are from prevalence-based perspective, and but our data from KMBD are from an instance-based perspective, and data from the GBD are for mainly international comparison, but data from the Korea National Burden of Disease Study measure the gap between subnational group, income level, blah, blah. So KMB study best for Korean specific analysis. We use detailed Korean data. For example, based on high level access to medical services and coverage rate for healthcare. And survey data are not used to concern about overestimation. Based on assumption relevant to Korea and epidemiology data reviewed by Korean experts, use of disability weight developed by Korean medical experts. We include subnational and socio-demographic estimate, and we have high-level transparency of input data. We used national representative data source to estimate epidemiological parameter. For example, population, we can measure directly registered with the Ministry of the Interior. And
insieme? Ma la fanno passare?
Yeah. And for mortality and life expectancy, we have cause of death statistics and life expectancy table from Statistics Korea. And for non-fatal health loss, we have National Health Insurance Service claim big data, except for original medical claim. Court data reconstruction using individual level claim data, and National Injury Hospital Discharge Survey from the Ministry of Health and Welfare. And length of duration, for length of duration and age of onset, we estimate using this Mode 2 program by WHO. I will introduce our National Health Insurance System. We have universal health coverage by National Health Insurance System. 97.2% of whole population we covered by the NHI, and other 2.8% covered by the medical aid program. And we have single payer since 2000, and we have freedom to choose healthcare provider, high accessibility to healthcare services. And we have comprehensive national health insurance benefit, and provider private dominant. That means over 90% of hospital beds are owned by private sector. Our government, Ministry of Health and Welfare, usually legislate and supervision for this national health insurance system. We have only one insurer, NHI's National Health Insurance Service, but the other similar insurer, HIRA's main function is health insurance review and assessment services. So our system's main role provided by our government, Ministry of Health and Welfare, and two main operation body. We have NHIS is insurer, and the other one is HIRA. HIRA's main role is health insurance review and assessment services. Okay. So we have such as follows. So big data and national level well-defined data sources. So we used disease and we used the national health insurance claim data. So we can differentiate disease and injury category by 4 levels. Level 1 means communicable, non-communicable injuries. And cause of death we got from statistics in Korea, but the proportion of garbage caused death was in 2012 25%. In case of disability weight, we used to estimate DW, which reflects unique social and cultural context of Korea. So we surveyed to drive cause-spec DW. This DW, this point will maybe explain detail, will give detailed information by our colleague Professor Ok during the panel discussion time. Such as we have our own questionnaire and, for example, BAS and the other systems. So we already published this data, this result. For example, updating disability for measurement of healthy life expectancy and disability life in Korea. And I will show, let me see, result and challenge. Our daily rate is steadily increasing. There was no significant change in the YLL rate. However, the YLD rate showed a tendency to increase during 2008 to 2018. The growth in the YLD rate is faster than that of the YLL rate. And the reading top 20 disease accounted for around 60% of total daily rate in 2008 and also in 2018. But the reading specific cause of burden was slightly changed from 2008 to 2018. For example, in 2018, low back pain is number 2 leading cause of burden. And daily rate by income level, we can measure this type of data because we, as I already mentioned above, we used National Health Insurance claim data. This National Health Insurance claim data has income of member, income and residence and other premium level. So we can differentiate the income level by our data. So the higher the income, the lower the burden of disease. And we have also differentiate by a subnational region. So subnational, we can measure subnational daily rate. This figure is the map of South Korea. So we in as of 2018, 115 regions are higher than the regional average daily rate of right this, and 135 regions are lower. Comparison of KMBD and GBD result. Originally GBD result I know model driven, but our study based on data driven, because I already mentioned above, our country has a well-defined big data system. So slightly in the viewpoint of result, the ranking of burden of disease is slightly different, but I think the same as. And the perspective for the measurement of daily, we can calculate instance by National Health Insurance System. So so far we used instance-based approach, but as we know, nowadays IHME adopted prevalence-based approach. We have several challenges. I already mentioned above. the perspective for Delhi, we used to instance-based approach, but the JBD study from IHME used to prevalence-based approach. So we try to find new methodology for prevalence-based approach in South Korea. And for the viewpoint of database for measuring non-fatal health losses in South Korea, coverage is high in the national health insurance system, but for example, mild illness, migraine, for example, with a high over-the-counter prescription may be so underestimated. In particular, it is necessary to consider whether diseases such as migraine are regarded as those that reduce health life expectancy. And data for small area, we saw for small area data, we have to consider using a Bayesian spatial model. So we'll strive for methodological improvement to more precisely measure the disease burden based on strong data sources. Thank you.
Thank you very much, Professor Yoon. We have last-minute changes of the program, so we will skip directly to the third presentation of this session, and then we will sum the presentation from the Professor Bredesen last hour. For now, we will know more about the experience from Japan. The title of the presentation is A Case Study from Japan, a National Burden of Disease in collaboration with the IHME, and will be presented by Professor Shuen Nomura. He is an Associate Professor of Health Policy and Management at the Keio University School of Medicine, and he's Assistant Professor of Global Health Policy at the University of Tokyo and Graduate School of Medicine. His current research topics include global burden of disease, global health policy and diplomacy, health emergency and disaster risk management, and COVID-19 response. This year, he has become a member of the independent expert group of the Global Nutrition Report, which is the official accountability mechanism for nutrition for growth commitments. Professor Nomura, the floor is yours. Thank you.
Hello, thank you very much. Can you see my slides?
Yes, and we can also hear you. Thank you.
Thank you very much again for your introduction, and nice to meet you everyone. My name is Shuhei Nomura. I am an associate professor at Keio University School of Medicine in Japan and assistant professor at the University of Tokyo, Japan. So I'd like to thank you everyone and all the organizers for having me today and their hard work in arranging this workshop and for everything today. And this is a wonderful opportunity that I can share my experience in the use of burden of disease in Japan. And okay, so this is the outline of my talk. I will first talk about the history of burden of disease study in Japan and how it has been translated into the health policy, and example of collaboration with IHME, and finally some lessons learned from my experience. So there is an interesting picture I'd like to show you. This is a cover page of Economist in 2010, whose issue title was Japan's Burden. And so what do you see? The Japan's national flag is made up of a red circle, and this sun is a symbol of the flag. And you can see a child who is carrying the red circle on his shoulders. So this picture means that Japan has a variety of issues and the children will carry them in the future. So, Japan's big health achievement in the past 50 years has been highlighted by universal insurance scheme, which is often called as UHC, universal health coverage. So people in Japan are free to choose healthcare facilities and can access relatively good quality of care at a relatively low cost. But the sustainability of Japan's health system has been threatened by super population aging and low birth rate and decreasing working age population and expanding healthcare expenditure and economic slowdown. So the good things about the burden of disease is its variety of comparability and comprehensiveness. So disease burden study can be used for the comparison of different disease status for different locations, different age group, genders, and others. So they are the very powerful tool to identify priority area in health policy in the situation of limited resources, both human and economic. And then very important person who is essential to the history of burden of disease in Japan, the Professor Shibuya. So the Professor Murray, the director of IHME, was his mentor. So they worked together about 20 years ago before the IHME was established. So Professor Shibuya was a collaborator in the first GBT launch in the Lancet in 2012, GBT 2010. So he is a person who created the foundation of the burden of disease research in Japan and established the relationship between Japan and IHME. Regarding my relationship with Professor Shibuya, he's my mentor. So Professor Shibuya and Professor Murray met more than 20 years ago when I was elementary school children. And then 10 years ago, I met Professor Shibuya and I did my master's degree in his department at the University of Tokyo. And after that, I went to Imperial College London in UK, and he also moved to King's College London. And we both backed to Japan, and we still work together. So the history of disease burden in Japan is quite interesting, isn't it? So my main burden of disease activities are wide-ranging. Much of my interest is how to use the burden of disease for policymaking and how to translate it into policy. So rather than estimating the burden of disease on myself, I focus on using the result of GBD estimate to generate new evidence and advocacy for policymaking. So here are some examples of how the GBD, the burden of disease can be used and translated into Japan's health policy. So this is a study supported by the Japanese Health Ministry. We examined how the allocation of public research funding by disease category was consistent with the burden of disease. So the Health Ministry is now very serious about effectively allocating its limited research resources. And as a first step, they wanted to know if research funding is balanced based on the burden of disease. And this is a part of the result. So we were evaluating research funding allocated by several ministries and government agencies in 2015 and 16. And using natural language processing methodology, we extracted text information related to disease name from research project summaries, research titles, and others, and finally mapped them to the GBD disease categories. The x-axis of this graph is the 22 GBD disease group, and the black bar are the proportions of total disease rate in Japan that each GBD cause group is responsible for. So first of all, you can see that quite a lot of research funds are allocated to cancer compared to its contribution to disease. On the other hand, musculoskeletal systems and cardiovascular disease are not well funded as compared to its contribution to disease. So of course, there are a bunch of limitations in this study, including data coverage, and the research has no country borders, but this analysis provides a snapshot of limited alignment between public research funding and disease burden in Japan. So of course, the disease are not all the determinants of the allocation of research funding. How much is burdened by healthcare expenditure, political priorities, also the public interest, and others are also important determinants. And secondly, I would like to highlight that the burden of disease is not only related to the work of health ministry, but also closely related to the work of the Ministry of Foreign Affairs. So in Japan, rethinking the strategy of offshore development assistance, ODA, has become an important political issue now. And an independent committee has been established with high-level politicians, the government officials, and the private sector, civil society, in order to develop strategic recommendations for future ODA strategy. And I am the member of the committee. And Japan's ODA strategies have been, largely influenced by political factors, such as historical and traditional diplomatic relations, and have failed to take into account, for example, the changes in the disease structure of low and middle income countries, which is, so-called epidemiological transition from communicable disease to non-communicable disease. So therefore, by using the burden of disease, based on data, we were able to consider and discuss today's health status in the countries that Japan has provided ODA. And then in its final recommendations, I highlighted the importance of designing ODA strategies based on disease burden, with a citation to the latest GBD studies. And another one that going back to my work with the health ministry. So Japan has a long-term national health promotion strategy, which is called the Health Japan 21 or HJ21. It started in 2000 and has focused on non-communicable disease prevention and control, with the ultimate goal of extending healthy life expectancy. So we are now in the final evaluation phase of the second term of this strategy. And we are also in the process of designing the new vision and setting the goals for the third term. I am also participating in this preparation for the third term, using the burden of disease to clarify the current health situation in Japan and to highlight important disease groups and risk factors that were not covered in the second term. And finally, this work is advocacy for the Nutrition Summit to be held in Japan at the end of this year, December. So in collaboration with the private sector and the civil society. So I think you may have heard of a food company called Ajinomoto Corporation, which is the Japanese food company that has been expanding its business, especially in Asian countries. So the University of Tokyo and Ajinomoto Company have been conducting a joint research for disease burden for about more than 5 years. And I am leading the research now. And we are now especially focusing on the salt reduction, sodium reduction. The reason is that the GBD study, also other burden of study, identified that the top dietary risk factors in Japan is high sodium diet. So you may know Japanese people consume about 10 grams of salt per day, which is double of WHO recommendation of 5 grams. So this slide shows Ajinomoto's annual business report for 2020, and it clearly describes that the company vision for 2030 considers the burden of disease and the dietary risks based on it. This is one of the example of the study for the forecasting of diaries in relation to salt reduction, but I will skip this because of the limited time. So next is our collaboration with IHME. So as I mentioned at the beginning, Japan does not estimate the burden of disease ourselves, but we use GBD estimates. So of course, we support the GBD cycle by providing data whenever possible. So this is a recent example. I'm not sure whether this is an offshore collaboration or not, but this study was co-authored by Payor, and he helped a lot, and other GBD disability weight experts like Jonita and others helped us. So one of the the burden of disease measures, the estimation of YLD, is living with disability requires the consideration of disability weight. And the estimated disability weight used in GBD do not include much data from East Asia, including Japan. So then we have attempted to evaluate Japan's own disability weight in order to see if there are any gap between those in Japan and those in used in GBD. So I'm sure somebody will talk about the detailed estimation methodology for disability weight. So in briefly, our methodology is exactly the same as GBD methodology. Although we have some new health status for evaluation. And then the results show that disability weight in GBD and disability weight in Japanese were roughly similar, very similar. However, of course, there are some differences. And much of the health status with higher disability weight in Japanese population were injuries, such as amputations and fractures. And on the other hand, mental and behavioral and substance disorder tended to be generally lower disability weight compared to those in GBD. And one more point, especially the recent one, but would you know that IHME is doing excess mortality estimate for COVID-19 for most countries? So in order to do this, the weekly or daily mortality data is necessary, including 2020 and 2021 this year. I mean, after the COVID-19 pandemic started. But the Japanese vital statistics, the mortality data, is very, very slow to be published to the public. And as of today, the weekly data is only available until 2019, before the pandemic. The only publicly available data for 2020 and 2021 after the pandemic started are the monthly mortality data, which do not allow for a very good estimate of excess mortality for COVID-19. So when I received such a consultation from IHME, I have just been working on a request from the Health Ministry of Japan to estimate excess mortality in Japan. Then now, only my team has access to the latest vital statistics for 2020 and 2021 from the Health Ministry, which is not normally available to the public. And then every month, I estimate the excess mortality for the latest month and publish them on this dashboard I created. So what I did here on this dashboard after being consulted by IHME was to publish the latest weekly data on this dashboard, including 2020 and 2021, that would allow various researchers in the world, including the IHME, to do excess mortality study for COVID-19 for Japan. So it was not allowed to publish the daily individual level data that I get from the Health Ministry as it is. But after negotiation with the Health Ministry, I could publish the data that I aggregated by prefecture and week. So the data just became available in July this year. And now the access mortality team at IHME is using this data and started making estimation. So now finally a challenge regarding disease burden from my experience. So first of all, I think it is very, very important to have people who can act as a mediator and can provide bridge between disease burden research and policy making. And I think there are quite a lot of disease burden researchers and GBD collaborators today, and there are a bunch of education and training on the concept of disease burden and the methodology. I attended the GBD IHME technical workshop some years ago, and it was really, really wonderful. So on the other hand, most of the disease burden researchers, I think, are the experts, the specialists with deep expertise in individual disease groups, disease areas. But I'm thinking that there are only a few generalists who can also analyze the policy and can translate the burden of disease into policy formulation. And another challenge is that the health issues now essential to collaborate with the private sector and the civil society. And regarding the salt reduction, as an example in Japan, and the many policy approaches might be possible, such as taxation and regulations, etc. But it is also important to encourage the active participation of the food industry, also the general public, to recognize the benefit of salt reduction for their own health. And finally, next disease burden study I'm going to do is a comparison with healthcare expenditure versus disease burden. So this will use the medical claim data, which took about more than 3 years to obtain for the data collection from the health ministry. But I am finally ready to do that. So this is the end of my talk. Thank you very much.
So thank you very much also for this really nice and interesting presentation, Professor Nomura. I didn't receive any specific questions for your presentation, but we have some others for the other speakers that we will discuss at the end of this session. So I will ask to all of you to stay with us until the end of this session at least. And in the meantime, I would like to introduce the Professor Saad Rawaf. He is director of the WHO Collaborating Center for Public Health Education and Training. And he is well known for his international work and contribution to global health. He is an advisor to the WHO on primary care, public health, health systems, medical education, and human resource for health development. He is recognized for his work in supporting countries to strengthen their health systems and service development, including Bahrain, Brazil, Iran, the Kingdom of Saudi Arabia, the state of Kuwait, Libya, Malaysia, and so on and so forth. The title of his presentation is The Burden of Disease and the Disability Weight, Framework Development and Experiences Toward the Implementing National Tools for Policy Decision. Please, Professor Rawaf, the floor is yours. Thank you very much.
Good morning, good afternoon, everyone, and thank you very much for the kind invitation. It's a great honor to be with you and colleagues from the Kingdom of Saudi Arabia and from around the world. I'm trying to load my slides if I'm successful, which is currently I'm not, but showing the competencies of an academic person. All right, I think we are online. All right.
Yes, we can. I can confirm that we can see perfectly your presentation.
Excellent.
Thank you.
Thank you very much. I'm sorry if you see the sun in my face. I tried to change my setting. Apparently, it's not easy with my computer link in my study at home. But today, London is exceptionally hot, about 30, 31 degrees centigrade, and it's very sunny in the beginning of autumn. Okay, I'm talking about the burden of disease and disability weight, and how can we use these in actually policy making, commissioning, and decision making. And some of my colleagues already shared their experience. I'll share with you my experience in the NHS National Health Services for about 23 years as a director of public health and 4 years as a medical director. So about 27 years in decision-making process at local as well as at national level. And I'm trying to be as practical as possible, taking into account that the transformation which is happening now in the Kingdom of Saudi Arabia, which I'm very familiar with it, and at the margin, sometimes a little bit at the center involved in it. It's a major undertaking, and It's really huge, and therefore data will be essential element of that major changes in the health system serving population of over 30 million. So I'll touch on data and sources of for management decision. I look at the disease of burden data, but also I'm adding the finance data and how to use the available data. But also I want to focus sometime, we need some primary data for decision making, although it's a bit slow. And how do we make these decisions? I think better information means better planning. It means better commissioning. Indeed, it means better health. And at the end of the day, it's better population and patient satisfactions. This is, I always put it as an overview for our thinking when we look at data and use the data. I decided to bring the last slide to the top and show you that this is the sort of framework which we need to think about. This is meant to be the last slide, but I will touch on some of the points I raised in the slide and look at how we use these such a framework in the decision making. I think first of all, we need population data. We need a small area population data. And if I say to you that the global burden of disease data by our colleagues in the Institute of Health Metric Evaluation, excellent source of data, but it is not, let me stress this, it's not helpful for quick decision making, and it's not helpful for local level decision making, and it lacks population data. So population data is absolutely essential. And this is not only a global data about the population. One of my colleagues did show a beautiful map of the earlier in the morning of 20 areas, the health areas within the Kingdom of Saudi Arabia with its population, etc. But this is not enough. You need a small area data because communities differ from one area to another. Even one district and next door road, it tend to be different population. And the work which I did helped me the assessment of our population over the years in Southwest London as a director of public health. I know my population precisely by street, by district, everything about my population, which is about 500,000 population. I know precisely who's there. The movement of the population is extremely well monitored, the age distribution. I can easily plot, cancer of the breast distribution in my area, just map it there because of the population data and small area analysis type of approaches. At the same time, you need to look at the big data in population health management. Dr. Khoja beautifully illustrated that this morning, but I think the big data, which is now part of the fourth industrial revolution, will have a great impact on the way we think and plan for health services and indeed at the decision making at local level. It will help us a lot. And I don't want to indulge on that issue of the big data, but if there are questions, perhaps we will expand on that. The health data, this is about really how healthy our population are. And these need a lot of work. Normally, such data is not available. And understanding your community, especially at local level, you need to understand the state of their health before you start making decisions. you know, in terms of how many hospital beds need, how many this, how many that. Unless you understand the state of the health of your population at local level, of course, the aggregate of that will be national. And of course, we have this burden of disease data. We have not only from our friends and colleagues doing excellent work at the Institute of Health Metrics and Evaluation in Seattle, but also we have a lot of source of burden of disease data. WHO got such data. Each country is working on their data. They are commissioning different groups. But these give you the big picture. It doesn't really much help, and I'll show you in a minute, in the day-to-day decision making. The most important data in commissioning and purchasing, and I know the kingdom is moving into the purchasing arena, which we experienced it in the United Kingdom in the mid-80s and until today. Purchasing is a very, very complex process. And yes, in the initial year, you keep the status quo and you look at the activities of each hospital, each provider within the public or private sector, and you tend to continue contract and services. But once you link it to the population data, the picture will change totally, because you will see there are certain group of the population who are disadvantaged, i.e., suffer from some sort of inequity, which you need to address it. Some people actually not accessing the health services. And the access to health services data is very important. And the most essential data, which is missing from almost everywhere in the world, you know, with the exception of a few countries, is primary care data. Primary care data is the one which is reflect the reality of what's going on in the community, what is going on in my population. And primary care data is not similar to the hospital data, because the hospital data is based on classification, international classification of diseases. Currently ICD-10, we move into ICD-11. But primary care data is not a well-defined disease. Majority of the people, they go to primary care, contact the primary care for symptoms. Cough is not a disease. It's a symptom of a disease. It could be nothing, you know. Psychosomatic, a lot of people, about 30% in primary care services in the UK are people suffering from psychosomatic, you know, people, they go, I got itching in my head, I got my body is shivering, but all this is recorded. Therefore, we have different coding in primary care. You know. In UK and some European countries, they use this called the Riyadh classification of diseases in primary care or contact. Wonka now developed, the International Organization of Family Physician, developed a new version of the Riyadh, which is called the Wonka classification of diseases in primary care. Having all this, you need to balance between the burden of disease at national level and actually the real activity data, which you see from day to day when you are in contact with the services. The financial data, which I show you how important it is. I mean, the financial data is very complex and require tremendous amount of expertise to understand how these financial data work. And if you are going to engage in purchasing, commissioning of services, and especially when outsourcing now already started in the Kingdom of Saudi Arabia, then the financial data will become absolutely essential, especially when you link it to the activities data. So you will find yourself possibly, it's really very difficult in the health services to get the precise cost of the intervention, because patients are not exactly the same. You know, a hip replacement sometimes could be done in 30 minutes by a surgeon, similar patient, similar age, similar size. You know, the operation may take 2 or 3 hours, you know, because of other complications, because of other comorbidity. So the financial data, normally we use it on the basis of banding. The UK use 6 bands, Sweden use 5 bands, some European countries narrowing the band depend on the type of the universal health coverage or insurance, etc. But happy to discuss it. Again, the valuable data, especially nowadays, in shaping our services are the patient experience and perception data. Patient satisfaction data are very important. And all the advanced systems are using very reliable data. There are methods of assessing that sort of data. We have a variety of management data which we need, especially workforce data, non-health data, social care data. So these all is needed. I put this sort of list of data which we could use, between community primary care and public health data. Incidentally, we are now in the precision public health. We can precisely define the burden of diseases in a very small locality. And we can differentiate between the impact of disease at national level with the impact of disease as a very small area within a small district. And that coupled with public health data, which are generated from health need assessment, which is continuous process and is mandatory. You cannot commission services at all unless you have good process of local health need assessment. And if anybody say to you that I have staff know how to do the health need assessment, forget it. Because 99% of people in public health, they don't know how to conduct health need assessment. And this is what we discovered in the United Kingdom when we went into commissioning. And the government actually commissioned James Raffrey and I to write the 3 books. I mean, James wrote the 2 books on need assessment, and I looked health need assessment for ethnic minorities published by the Department of Health. Because we discovered that our public health workforce, they don't know how to conduct proper health need assessment. And this is the hospital data. Social care, you cannot separate between social care and health services. Because we discovered, for example, that during COVID, we have over 36,000 people actually treated for COVID in hospital that could not be discharged at home because nobody can take care of them. So the health and social care are very much linked. We shouldn't forget mental health data, and it is how it's interlinked to the other hospital data. And I already mentioned the finance data. I summarized this in terms of how do we use the primary care data and hospital data from NHS England. This is not my slide, this is slide I borrowed from NHS England. It's really, it's very important to describe the activities over time. And this is the process of describing. And if you want to move into commissioning, then you need to precisely master the art of predicting, i.e., I cannot buy the same services every year. So I'm predicting increases or decreases in the service. It doesn't matter if you get it wrong. I mean, trust me, I got it wrong a few times. But at least, I have some prediction, and I go with 10% plus minus mistakes, And I always evaluate that sort of evaluation, and I'm refining the process and how to use the data and matching various data. And I try to compare myself with other districts as well of similar background, especially commissioning tend to be at local level. Very few services tend to be commissioned at national level. And I will audit what I'm doing, but also I will investigate an outliers. If there's something happening, and I can tell you a simple story very quickly. When in one area, I found that the burden of diseases, of heart diseases was extremely high. And I invested about $1 million investigating, this is the primary data, which I talked about it earlier, investigating what is this about, you know? And by the time I discovered the community majority South Asian related to the type of food they eat, I initiated a program, a very big program, allocated a lot of money to reduce coronary heart diseases. In 10 years, we managed to reduce it by 50%. You see, this is it will be useful for me to look at global level. When I look at the global burden of disease data, this is what I get. It's general data. Yes, it's important, the diet for me, etc., in terms of shifting policy, shifting my thinking, or I'll go and research it in my country. But I think it's not sufficient enough, not sensitive data to make decision which will have a great impact, day-to-day impact on the population, which I'm doing. I would understand that the population growth, the population aging, the changes in the mortality, etc. It will give me a good overall picture, but it will not give me the details which I want. And by the way, these are all based on estimate. These are not real data. These are estimate data, which we need to look at it grossly in terms of how it's moving from one area to other. It is, as I said, very useful for me to compare with other countries and neighboring countries and so on and so forth. I just want to go quickly through this in terms of cause of death, level of disability, etc. But let me share with you something about expenditure data and finance data. I have this almost the last 2 slides, and I would like to have some discussion. I mean, this data from the USA, and we looked at the data. I can share the slide with you too, from United Kingdom as well. And immediately after this one published in the United States, we worked, I and my team, to look at the data in London, and it's exactly similar. It's almost give and take, despite we have totally different system. And United States, they don't have health system, defined health system, while United Kingdom have a national health service. If you look at in the United States, 1% of the population using 20% of the health resources. And the health resources in the USA is huge, you know. They spend about 16% of the total GDP, and the GDP of the United States is the largest in the world. So you can imagine the magnitude of that. And if you take 5% of the population, they consume about 50% of the resources. And therefore, you need carefully to analyze these data, because in commissioning, these services need to be defined separately. These are very complex services, which very few patients will benefit from, you know, and therefore it needs to be defined very carefully. I'll just give you an example. Again, another one. I mean,
Professor Rawaf, you have no more than 2 minutes. Thank you.
I have only 2 slides.
Okay, thanks.
Look at the correlation between health access and the quality of services and spending per capita. You will see that countries which is spending more actually get better services for their, and such analysis is important. I mean, this is one of my PhD students from the GCC actually did that using the HAC index for services. Thank you very much indeed. I look forward for the question. I said I'm finishing in 2 slides.
Very much. Thanks a lot also for this interesting presentation. As I anticipated, we have some minutes for the discussion before to close this session. And I saw the hand raised by Professor Juanita Axman. So please Professor Agasman, if you can tell us your question.
Oh, sorry, that was a mistake.
Yeah. Oh,
Sorry.
okay. Okay, don't worry. It's fine. We have also some questions in the chat. So the first one is for the Korean experience. Actually, it was really of interest for our participants, and they asked for additional materials and where they could be downloaded, and if there are also some interactive dashboard.
A question to me?
Yes.
Yeah, I mean, I don't know what additional material the colleague who asked, but certainly any additional material you want in terms of how to use data precisely or public health decision data and population health management, more than happy. Just contact me and I'll share with you the data and the information you need.
Yes, thank you. Maybe also Professor Yoon can add some others information.
The question was going for the intervention on South Korea. So maybe the South Korea, the question was about if there is a dashboard created for representing the results. Professor Yoon, if you are connected. I think he left.
Okay, so we will share them. Any material we'll get from from Korean experience on calculating the. It's really an excellent example of how we can do a national level burden of disease calculation, capitalizing on insurance data and the data from primary care that they collect, utilization data, hospital data, developing a disability weight that account for the people from their country. We will reach out to Prof. Yoon, and we will share it to the all attendee, inshallah. And I have a question. Really, maybe we can discuss that question during the round table. Based on the experience in Korea, why they elect to calculate and or use the disability weight by having a panel from healthcare worker rather than the population. So maybe we can discuss that in the round table, or if any of the panelists has an insight or an argument, what would be the better approach to be used. We can discuss it that now or in the round table. It's up to you.
Abdullah, if you allow me, I mean, I'll come here because this is close to my heart. The issues of disability weight, you know, I don't know how much it will help in decision making. I mean, it will assess. It's good for research, you know. But I mean, the DALI and other measures of disability, the HARS method of assessing function, loss, etc. All these will be very useful in clinical assessment and in shaping services to this group. But I doubt that it will help in the commissioning process, you know. I mean, I just want to see how these could be used in the commissioning process, Dr. Abdullah. Over to you.
Yes, sure, Dr. Salman. Yes, so it's the same question from my side. We hypothesize that using a weight or disability weight will help us in taking into account the cultural and ethical and perspective of the population. So in a traditional way, in a public health, we usually use the prevalence of disease, for instance, and condition, or in traditional insurance, they use that utilization and the cost. If we introduce the disability weight to the equation, it will help it will help us in comparing apple to apple. So we can compare, for example, if we have a high prevalence of headache or migraine, and the disability weight based on on our population is very low, whereas infertility is very high. It's almost equal to loss of equal to death. So it can guide the priority where we can invest and direct our activities. So it can be used. Our hypothesis can be used in a wider what they call it priority matrix. So it can be one of the inputs to support the decision, accounting for the value of the population at a priority in the design.
Yeah, I mean, my question was how to translate that into commissioning the process, because this is about money. It's about defined services. When it comes to disability services are well defined, but how the weight in terms of disability weight will change that concept of commissioning or purchasing. You know, I would be interested in to see how that would work.
Maybe we are starting anticipating the discussion. We will focus on shortly with the round table. So maybe if we don't have other question from the chat, we can suggest to have 10 minutes break, as we are running in delay, and then we come back with our two speakers before getting into the round table finally. Is that okay for everyone? So we can mute and come back into 10 minutes for going ahead. Thank you so much for your continuous presence, and also thank you to all our panelists. Okay, so we can go back and restart the presentation. I think to some extent with the latest question, we have somehow started the discussion, and particularly whether this measure of population health can be used for the commissioning, so for the financing versus for the clinical assessment. So the next session, I think, can really bring some more insights that could be useful then for the roundtable, as we are going to deep dive into two different in this different assessment methodology. First of all, we have the intervention of Professor Alessandro Cassini, challenges and opportunities in estimating the burden of infectious disease and antimicrobial resistance. I'm pleased to introduce Professor Cassini to you. He's a medical doctor specialized in public health and epidemiology. He also earned an health policy planning and financing Master of Sciences. He worked for more than 10 years at ECDC, so the European Center for Disease Control, as responsible for the estimation of the burden of disease in infection disease, developing the risk ranking methodologies and exploring also how to translate the scientific research into policymaking. From 2019, he joined the World Health Organization in the Infection Prevention Control and the Technical and Clinical Hub. Here he is also responsible for coordinating the activities related to sepsis. Recently, in 2021, he joined the WHO Antimicrobial Resistance Control and Response Strategy Unit. So thank you so much for joining this workshop, and Professor Cassini, the floor is yours.
Thank you all very much for the invitation and for the opportunity to present about the experience of estimating the burden of disease, in this case of infectious diseases that have some very specific challenges related to them. So Betiana and Professor Signorelli and all the colleagues from the Kingdom of Saudi Arabia, again, thank you very much, and it's my pleasure. I will maybe just dive in very quickly, given that we have a limited amount of time, just to let you know that this B-Code project that we were calling the Burden of Communicable Diseases in Europe started a long time ago at the end of 2009. It was funded by the European Commission, which is the funder of the European Center for Disease Prevention and Control. And it was initiated by the, at the time, director of ECDC, who is now Deputy Director General of WHO, Susanna Jakob. The stated objectives were to introduce an evidence-based approach to health description, so to foster an overview of surveillance. So it wasn't only to actually estimate the burden of disease, but it was also a way to look at the surveillance data that ECDC was producing, its quality and the availability of the data. Then we had another challenge, which was to translate what we were finding into complex information that was useful for decision makers, and hence be used for planning and prioritization in terms of health. We decided since the start to go for a common currency, something that actually allows you to compare apples and pears, and allows you to compare very different diseases like hepatitis or influenza. And then we expanded this to the estimation of the impact on health of antimicrobial resistance and healthcare-associated infections. And I'll show you what were the results of all this work. But before I go into that, I'll leave the talk about disability weights to my colleague and old friend Juanita, who will be speaking after me. But just to say that we did initiate a project, a study to look or to estimate the disability weights in European settings. thinking that they would reflect a little bit more the values and preferences of the European population. What we did find was that actually these were not very different from the ones that were used globally until that moment. And actually, yes, the disability weights that were estimated in Europe were then integrated by Josh Solomon into the global estimations of disability weights. And there we also saw again that the differences were actually very little. This, and I'll let Juanita talk more about this, but this was probably due to the fact that disability weights are a relative reflection of the disability of diseases. They are not absolute. So in general, even if one is blind in Sweden or in a low-income country with less let's say, opportunities to live a full life, the relative disability of being blind is similar in those two contexts. The approach that we decided to use is an incidence-based approach. So it's different from just looking at the prevalence of diseases. And in order to do incidence-based approach, you start with an infection, and then you try to find out what happens after that infection. A few days afterwards, a few weeks afterwards, and even a few years afterwards. And we did that by mapping diseases according to what we called an outcome tree. So it starts with an infection, as I was saying earlier. You can have an asymptomatic infection or even symptomatic infection. This happens for most diseases. Even the symptomatic infection can be complicated or severe or uncomplicated. Then a person can have permanent disabilities or recover or have some transitional sequela that will then bring to other sequela or permanent disabilities, or obviously die from it. All of these arrows actually carry a certain risk, or that is expressed by a percentage with uncertainties, obviously. And the boxes that we call outcomes, so therefore the actual state of health, is reflected by a duration and by a disability weight. So this is an example from the BICO toolkit, which is a software that we created while we were working on this study. And this toolkit actually helps anyone estimate burden of disease, obviously according to methodological choices that I will show a little bit more now. And this is just an example of hepatitis B and how it looks like. It's one of the most complex outcome trees. Not all of them are like this. Rabies, for example, just has symptomatic infection and death. But this is a more complicated one. And the information on the risk of developing sequelae, the duration, etc., were all extracted from systematic reviews of the literature, trying to focus on the European population. I was also asked by the colleagues from San Donato to focus a little bit on the methodological choices, and I would almost call them value or ethical choices that we made for this study. And I'm just going there. So there are a few points that you have to decide when you decide to estimate disability DALYs, which are what kind of life expectancy table you're going to use. Are you going to discount for time? Are you going to discount for age? And we agreed with some of these statements made by Chris Murray and his colleagues. Chris Murray is the director of the Institute for Health Metrics and Evaluation. They are the ones that are actually working with and doing the estimates for the global burden of disease. And we agreed that a reference standard table, life table, is what we were going to use, because regardless of where people are, everyone should have the aspiration for a healthy lifespan. Therefore, we didn't look at the life expectancy in Europe, or we did not use country-specific life expectancies. We used a standardized global table. Obviously, it was not very different for Europe, but still there are some slight differences. We also decided to use the same table for males and females because there is no reason that we know of for males being having a lower life expectancy apart from disabilities that are due to risk factors. We also decided to discount time, and this was stemming from the idea that investments that are done today in a way should consider the near results from the investment instead of considering only the long-term impact of these investments. And as it says here, it would be unfair to sacrifice, an unfair sacrifice to ask from the current generation an investment only for long-term impacts. And then last but not least, we decided not to age weight, considering that the impact on health should be, at least when we're looking at health and not health economics, the impact on health should be the same regardless of the age. Therefore, this is a quick summary of some of the methodological choices that we decided to include. So we built a toolkit for the estimation of the burden. It's user-friendly, it's free, it's flexible. It does not contain, we decided not to use age weighting. It is incidence-based approach and pathogen-based, but actually not only pathogen. I'll show you some syndromes later. And time discounting can be used as an option. It does Monte Carlo simulations, which is a great way to manage uncertainties, especially when there are so many of these. And then you can choose the number of times you turn the model in order to produce results. We call them iterations. So I was going through the different data that we needed to collect in order to estimate the burden of infectious diseases, the health outcomes, so what happens when you get a certain disease, the percentage of what is the risk of developing sequelae or dying, the duration of these health outcomes, the disability weights, and then finally, one of the most important pillars of the estimation of a burden of disease is the number of cases. So on the number of cases, I could use up probably all the rest of the time that we have, but I'll try to be very quick. When you have surveillance of basically all diseases, generally what you see is really a tip of the iceberg. There are many more people that actually will have that disease but are not collected or not flagged or reported for some reason or another to the surveillance system. This is what we call a surveillance pyramid, and it sort of tries to understand where are the different layers of people and why they are not captured. Some people are not captured because they don't even go to the health system, either because they don't have access or maybe because the disease was not so disabling. And then other people do go to healthcare, but they are not reported for, as again, many different reasons. So we had to work on all the 54 diseases that ECDC is responsible for surveying on these layers in order to really estimate what was the total impact or the true incidence, if one can say it that way, of the different diseases that we were looking at. There are a number of slides explaining how we did this, but just very quickly, I can tell you that it was a case-by-case approach. Some diseases we could use mainly the surveillance system. Other diseases, very little we could use the surveillance system, and because of unavailability of data, because the quality of the data was pretty bad, or for some diseases, only children are reported, for example. So we had to find out what was the rest, the other side of the moon. So there's no one golden bullet answer for approaching this. It really depends on the healthcare system, on the public health system, and on the disease itself. These are the results for what we call the community diseases. of the burden of disease in between 2009 and 2013 in the European Union. And as you can see, influenza has the highest burden, much higher than most other diseases, especially those that are preventable through vaccines. Tuberculosis and HIV still have a pretty important impact on the population health. We did not expect a high burden of invasive pneumococcal disease, so this was really interesting to look. And then come different other, both respiratory or foodborne diseases. But then we want to apply this methodology to healthcare-associated infections, because we had the understanding that they were pretty impactful in the European Union. Problem is, whoever will have a healthcare-associated infection, by definition, has a comorbidity, has another reason for actually being in the hospital. So we really had to manage, and Brecht, Juanita, again, thank you very much for all the advice you gave us on this. We really had to manage the comorbidities and how to deal and model that. This is looking at the incidence of different healthcare-associated infections. And as you can see, urinary tract infections, surgical site infections, and even pneumonia have the highest incidence. But when you estimate the burden, as you can see, the picture completely changes. So this is already a first hint of how useful it is to do a burden of disease study. It actually completely changes the scenario and the prioritization of the disease or the impact on health of the diseases. So as you can see, pneumonia and bloodstream infections are by large the highest impact, the diseases or the syndromes that actually impact the highest. And last but not least, we decided why not try to use this methodology on antimicrobial resistance. And this was extremely difficult because of the fact that AMR is a complex scenario of different syndromes, different bugs with different resistance to different drugs. So the combination between bug and drugs can change a lot. This is the work that we had to do before just to estimate the incidence. I'm not going to go through all the details, but just to say that each one of these small green boxes required a large number of experts and data management to achieve. We also had to look at the attributable mortality, because a lot of people that do get infections with antibiotic resistant bacteria, for example, will have comorbidities or are already, in a way, have already other health issues. So we had to do a comprehensive systematic literature review, scoring all the papers, and then make some final decisions that brought us to this table. This is the results. As you can see, there's a few bug drugs that come out as being very impactful. But interesting point that we found is that 75% of the total burden happens in hospitals. So the issue of AMR in European countries is mostly a healthcare issue more than an agricultural issue or other kind of, let's say, drivers. And if you actually compare the burden of AMR to other diseases, you can see that it's comparable to the combined burden of influenza, tuberculosis, and HIV. And if on top of that, you even put the healthcare-associated infections, then you can actually see where the main challenges in the European Union lie in terms of management of infectious diseases or in terms of impact. So very quickly, as I was already mentioning earlier, when you do a burden of disease study using a composite health measure like DALIS, it completely changes the ranking of the priorities of diseases, as you can see. Another useful output is a very age-specific look or scenario at the burden of disease. So it was interesting to see that in children, it's mainly vaccine preventable diseases that have the highest impact, or that in the adult population, it's HIV and tuberculosis that have the highest impact, or that in the elderly, it's mainly respiratory infections that have the highest impact. Obviously, we were working with our friends that work on vaccines and then vaccinations, and we did some modeling in order to show that without vaccination, so for example, there was a measles outbreak in 2010 in Europe, especially among populations that were not vaccinated, how this actually completely changes the ranking of these diseases. I was asked from the European Commission to say what were the diseases, the foodborne diseases with the highest impact. And when we produced these results, we showed that Campylobacteriosis was the disease with the highest impact, and some legislation on management of poultry actually resulted from this small study. And legislation at the European Commission means that it trickles down to all the countries of the European Union. We also were looking at what was the, let's say, how much one needs to vaccinate in order to manage a disease like measles, and we confirmed that you need over 95% vaccination for a disease like measles. Something that we already knew, but it's nice to confirm with some data. We were asked by Slovenian Ministry of Health to look at the burden of tick-borne encephalitis, which is endemic in Slovenia, because they had some money to provide vaccination to their population, but they didn't know exactly which population to vaccinate because they didn't have money for the whole population. So they looked at the incidence and they were about to start vaccinating those over 50 years old, but we challenged their decision and showed them what the actual impact on the burden of health was due to tick-borne encephalitis, and we showed that it was mainly in children, and this reverted their national legislation on who to vaccinate for free. We looked at country-specific burden of antimicrobial resistance, showing that there were some countries that had a very, very large problem. And if you can look at the red part of these bars, those are mainly infections, AMR infections that happen in hospitals. So that actually translated into some recommendations. This is another way of looking at it, and these recommendations were translated, for example, in the National Action Plan for AMR in 2017 from Italy. We also were looking at how this changed in time, and we were seeing that even despite all the work that was done to manage MRSA, for example, it did still continue to rise. But really what was shocking was to see how much carbapenem resistance was rising, and that is a problem in hospitals mainly. And so that helped identify where the real issues were more specifically. And in some countries like Italy and Greece, the rise of carbapenem resistance was not 6 times, but 80 times, 80. And then we worked with the OECD to estimate the burden, the economic burden of AMR. And this was possible thanks to the modeling that I just showed you until now, looking at different kind of interventions. And we saw that most interventions were not only cost effective, but were actually cost saving. So you invest some money and you actually get some money in return. And not only you do that, but you also save lives. So hopefully, these are some of the conclusions of this very interesting report that I think OECD is updating right now. And so, for example, given that biggest amount of the burden is due to healthcare-associated infections and AMR that happen in hospitals, hygiene interventions in healthcare settings were seen as being those that had the biggest impact. And so hopefully even through what happened during COVID, this probably was an opportunity to step up a little bit the infection prevention and control. And we also looked at some packages and how much of interventions and how much these would actually save money and save lives, specifically for each country. So thank you very much. These are just a few slides to thank the large number of people that were involved in all these studies. And I can go on with many other slides on this. So thank you.
Great, thank you so much, because you really go through different insights, but also you raise many challenges. So I think this will drive us directly to the final discussion, as far as you showed and go very clear on the challenges that for each summary measure are required to go through, especially what kind of decision should be taken from the methodological viewpoint, and you show decision taken particularly by the ACDC. You also raise careful consideration regarding the assessment of national-based disability weight. As you said, it might be similar at the very end. But then you show at the end a very interesting example of how the calculation of the disease burden can actually support the policy making with priority setting, and then with an economic, or at least a cost effectiveness assessment, maybe as ex-post impact economic assessment. So this is very interesting. Let's go now to more in depth with the disability weight. So with Professor Juanita Axma, who is a very important expert in the field of disability weight calculation at national and international level. So she will bring us into more detail about the different technologies and the challenges for the calculation of the disability weight, and so that we hope will fill up our final discussion. Let me introduce to all of you our participant, Professor Juanita Axma. She is assistant professor at the Department of Public Health of the Erasmus Rotterdam. She is a member of the Health Technology Assessment and Implementation Research Team. Her projects revolve around the injury, epidemiology, outcome measurement, and the burden of disease methods. She has been the PI of several disability weights projects, including the 2013 European Disability Weight Project. Currently, she's also chairing the Non-Communicable and Injury Working Group of the European Burden of Disease Network. So thank you so much for being here, and the floor is yours.
Well, thank you very much. And thank you very much for the opportunity to give a presentation here. I was asked to give an overview of best practices of new elicitation or of disability weights, or adoption of existing disability weights. And before we go into that discussion, I think it's better to start with a sort of technical background, because before you can make a discussion on the best practices, you should actually dive into the technical aspect. So it's quite a technical presentation, but I hope it's clear enough and it will fuel our discussions afterwards. So first of all, we have been talking about the disability adjusted life here the whole day actually now. And just briefly recap what everybody else already said. The disability adjusted life year consists of two components: the years of life lost and the years lived with disability, so the YLL and the YLD. And the YLD, the years lived with disability, which is the morbidity component of the DALI, is calculated by the number of prevalent cases times the disability weight. And this is in case of prevalent YLDs rather than incidence-based YLDs. So this is the formula for prevalence-based YLDs. So for this YLD component, you need a disability weight. And the disability weight quantifies the severity of health outcomes as a percentage reduction of perfect health. So this is maybe a little bit difficult sentence, but it actually means that it signifies how severe a certain health outcome is compared to other health outcomes. So for example, if a disability weight for severe traumatic brain injury is 0.5 on this 0 to 1 scale, then 2 people living with severe traumatic brain injury in the year of interest, for instance, 2020, would be equivalent to the loss of 1 year due to premature mortality. So that's how you can compare those YLDs to YLLs. You need this disability weight. So the disability weight is essential for calculating DALYs, and its value is assigned to living with disability. So it signifies something about how it is to live with the disability or the severity of living with the specific disability. And it has a value that is anchored between 0, which is perfect health, and 1, which is equivalent to death. And the value reflects this relative severity of a health state. And here in this illustration, you can see this scale from 0 to 1. So 0 is perfect health and 1 is equivalent to death. And minor hearing loss is all the way at the perfect health end of the scale, whereas schizophrenia, the acute state, is at the other end of this disability weight scale. And in between, you see some other health states, migraine, amputation of both legs, which are also placed on this 0 to 1 scale. So the disability weight is based on preferences, and I will use this word a lot during this presentation. And what are preferences actually? So preferences are quantitative expressions for health states that reflect the relative desirability of health state. So it says something about how desirable a certain health state is compared to another health state. So how desirable is a mild traumatic brain injury compared to, for instance, the amputation of both legs. So this is a preference. It says something about the relative desirability of those health states. How are disability weights actually derived? So I have this scheme to explain in a nutshell. It's very short, this explanation, but just in a nutshell how you derive disability weights. Because it's not only the calculation of the disability weights, it's actually the whole health state valuation exercise or the disability weight survey. So first of all, you start with a health state description. This health state description, for instance, mild traumatic brain injury, is then evaluated. So you think about this health state and you think, well, how desirable is this health state? This results in preferences, which I talked about in the previous slide, and these can be transformed into disability weights. So first you need the preferences for those health states, and then you can assess the disability weight based on those preferences. Now for the health state description, you have several choices. There's a sort of choice menu. You can either have a short description that is a label like hip fracture, or you can describe it in a more lay terminology. So describe what a person experiences. And in this case, for a hip fracture, this person experiences pain and stiffness in and around the hip area. So that's the health state description. Then you have a number of people evaluating the health state. These can, for instance, be all the people who are here in this meeting, but it can also be people from the general population of, for instance, the Kingdom of Saudi Arabia. But it can also be health professionals, like in the study of Professor Yoon. So you have different options for the panel of judges that will evaluate those health states. And I keep saying panel of judges. With this, I mean the panel composition. Then, based on these evaluations of this group of people, you have these preferences on a scale from 0 to 1, which you then change into a disability weight. So this is, in a nutshell, how you assess disability weights. Well, what is actually recommended? Because I already talked about health professionals versus people from the general population. What is now recommended for disability weights? So who should be the panel of judges? Well, it is recommended to use disability weights that are based on societal preferences, so the preferences from the society, because burden of disease studies are primarily used as a tool for guiding decision-making on resource allocation at the population level. So people from the population should say something about the preferences, and then these can be used to guide decision-making on resource allocation. Well, looking at what has been done actually in disability weight studies, there are also a number of disability weight studies that used health experts for these health state valuation or disability weight studies. This is in this graph, you see an overview of a very recent systematic review of disability weight studies, and you see the number of disability weight studies that is published by year. And you can see already that in the years after 2010, there's a high increase of disability weight studies. So that's already something that we found very interesting and probably propelled by the GBD 2010 study, which I will talk about a little bit later in this presentation. But what we also saw is that the panels or the disability weight study used more and more general population panels. So the societal perspective for the disability weights. So which sets of disability weights are there actually? Well, there are several widely used sets of disability weights. The first one that is currently a lot used, so I'm talking now about 2010 and onwards and not further in the past, is the 2010 set of disability weights from the GBD study. So this is a global set of disability weights that should be used globally, so can be used globally. And you have the 2013 set of updated GBD disability weights. This is also a global set. So you have either global sets or regional sets. Well, the global burden of the global disability weight study was based on two components. The first component was a population-based household survey in 5 countries. So people from the general population were asked to evaluate a number of health states. These people were from Tanzania, Bangladesh, Indonesia, Peru, and the United States. So more than 13,000 people from those countries. And then in addition, the second component was an open access internet survey. So everybody was of course, having access to this internet survey, was able to fill out this survey and to evaluate health states. And in this second component, there were more than 16,000 people who filled out these surveys. And what was noted is that in the open access internet surveys, that were mainly health professionals or people with a higher educational level who filled out those surveys. The reference to the disability weight study I've included, and all the studies that I mentioned in my presentation, I've included in the slides, so you can easily find them online if you want. So next to global sets, you also have regional or country-specific sets of disability weights. Examples of these are the 2012 set of European disability weights, which Alessandra Cassini just mentioned for the B-code study. There was also the 2016 set of the Korean disability weights, which was mentioned by Professor Yoon in his presentation. And of course, the very nice 2021 set of Japanese disability weights, which was mentioned by Professor Nomura in his presentation. Of course, there are many other country-specific disability weights, but because these were mentioned in the presentations before, I wanted to mention them specifically. So you have the choice of either, if you're performing a disability or a DALI study, you have the choice of using a global set of disability weights or a regional specific set or local set or country set of disability weights. So for the European disability weight study, I was the project leader of this study, so I will explain a little bit more about the methodology. For the European 2012 disability weight study, we replicated the GBD 2012 or 2010 disability weight study, but we used internet surveys in 4 European countries. So our interview technique was a little bit different. We didn't have face-to-face interviews, but we used internet surveys. And our participants were from Hungary, Italy, the Netherlands, and Sweden. We chose these countries because we thought, or we investigated, that they were a representative for the 4 regions in Europe. So in total, we had more than 30,000 participants. But why actually did we do this study? Well, first of all, there was a need for additional disability weights for infectious diseases. This was for this B-code study, or the burden of communicable diseases in Europe study that Alessandra just presented in his presentation. And also there was a need of disability weights that were based on the preferences of Europeans. Because at that moment, with this new measurement method of the GBD, we did not yet know if there were any differences in health state valuations between people from different countries. So that's why we performed this European 2012 disability weight study. Well, when we compare the country-specific disability weight studies to the global burden of disease disability weight study, we see that for the European study, if we compare the disability weight values, we see that most values were very similar. This was also mentioned by Alessandro. So we found a lot of agreement on disability weight values, but for some health states, we found some differences. So for instance, fractures, injuries, fractures got lower values, and lower disability weights were found for severe infection. If we compare the GBD versus the Japanese disability weights, which was very, very nicely done in Professor Nomura's publication, we see that there was much more disagreement between the Japanese and the global disability weights. For instance, there were lower disability weights for mental, behavioral, and substance use disorders, and higher disability weights for health states with pain and sensory symptoms. So this already indicates that there may be some differences in preferences between persons from different countries or cultures, and that will then also result in different disability weights. Yeah, so this already gives some fuel for discussion, I think. Is it needed to have a local disability weight set? And why are the European disability weights so much more similar to the GBD disability weights than those from Japan? I think an explanation for it is that the Global Burden of Disease Disability Weight Survey already included a lot of people from Europe. So there were already a lot of Europeans in the group of participants. Whereas for the Japanese participants, there were only very, very little, if I remember correctly. So the Global Burden of Disease Disability Weight set already reflected the preferences of people from Europe, whereas this was not the case for Japan. And maybe also for Japanese participants, cultural or other social aspects play a bigger role when evaluating the health state. So currently, I looked into, of course, the Kingdom of Saudi Arabia. Currently, there are no disability weights that are based on the preferences of the general population of the Kingdom of Saudi Arabia. And looking at the Global Burden of Disease, the Global Burden of Disease Disability Weight study, where you here see the map, you see that there was only a very small number of participants that were from the Middle Eastern region. So darker red shows a higher number of participants per country. So for instance, in the US, you see that there are more than 500 participants in the disability weight survey of the Global Burden of Disease study. The same for Australia and the UK. Whereas for the lighter shaded countries, particularly those with a very light shade of pink, there are very low numbers of participants in the global burden set of disability weights. So this already shows that the global burden of disability weight set does not reflect the preferences of the people from the Middle Eastern region as much as it does from other regions. This map is actually from the publication of Joshua Salomon on the Global Burden of Disease 2010 disability weight study. I looked into other health state preferences studies because health state preference studies are not only done for disability weight studies, they can also, for instance, be done for other types of applications of health state preferences, for instance, for EQ5D value sets. The EQ5D is a quality of life measuring instrument, and you can use value sets to transform the responses of the group of participants into a number between 0 and 1. And one of the studies on health state preferences in an Arabic-speaking country, in this case it was Egypt, showed that there were marked differences in health state preferences compared to other countries. And actually a lot of similarities between more Southeast Asian countries. So particularly health states that were characterized by mobility problems were evaluated as worse compared to other countries. And also people were very much not liking health states that would put a burden on their family while caring for them. So the GBD set can be used in a national study on the burden of disease in the Kingdom of Saudi Arabia, but possibly these disability weights do not reflect the social and cultural context of the Kingdom of Saudi Arabia. Previously, in a previous presentation, Professor Yoon also explained something about the societal and cultural context that may impact preferences, health state preferences in this case, and this may also be the case for the Kingdom of Saudi Arabia. So what is best practice? This is actually quite a difficult question to answer, I think, and I don't think I answer it. I just give some options that we maybe discuss later on. So the first option with disability weights that you need for a national study is that you use existing disability weights from existing sets of disability weights. So for instance, the global burden of disease disability weight set. But then you assume that these disability weights reflect the preferences of the population under study. So then we assume by using those disability weights that they reflect the preferences of the people from the Kingdom of Saudi Arabia. The other option, so the second option, is to perform a national burden of, I say here national burden of disease study, but I mean national burden of disability weight study. But this choice depends, I think, very much on the population that is under study. So for instance, if I would do a national burden of the disability adjusted life years in the US, I would not suggest to perform a new disability weight study, because you already saw in the previous slides that people are already very much represented in the global burden of disease disability weight set. So it depends on the population under study. It depends also on the needs for the national burden of disease study that is performed. So are all the health states that you want to study, are there disability weights available for them? Or do you need a new disability weight study to assess disability weights for new health states, like we did in the European disability weight study? And of course, it also very much depends on the resources that are available for the study, because particularly those larger general population studies with a large number of health states that you want to evaluate are you need some resources for them to perform them, also to reach the people that you want to reach, because you not only want to reach the people with a high education and access to laptop or other devices, but also on a different level, I think. So lower educated people with lower access to those devices. So this concludes my presentation. I hope I have informed you more about disability weights and also best practices. And I give the word back to Vincenza.
So thank you so much, Professor Agasma. So we were waiting for Brett, but it seems he has some issues. So in case he arrives, he will join with us at this point with the round table. So I think we can open now the discussion, taking advantage of the various inputs that we get from all the panelists across the morning. And I would like to open this discussion to give a question for all of the panelists. So basically, we get more into two types of summary measure of population health, the disability weight and the burden of disease, whereas we saw there might be other different measures. We saw also the complexity of building up such a measure, but I don't think that out of all the presentation, now we are discussing about if it's really worth of measuring such elements either locally, nationally, or internationally. I think this is quite a common point across all of you. What is really the problem and that we want to answer now is about how actually to this kind of measure can be used, as far as the current question, particularly for the Kingdom of Saudi Arabia, is taking the investment from the beginning. So first of all, there will be the investment in collecting the data, and later on an investment for building the utilization of such a measure. So I see there are two types of questions that here comes directly from how we can use such a measure. The first one is how we use it, and we can translate it into the policy, and particularly into this decision making. And here, more or less, also providing different framework, we discuss about how this information can support the priority setting. We saw in this case priority setting either to better understand the population, target specific intervention, prioritize, or shift previous investment into new areas, as we saw for the case of Japan. When it comes instead to the reasoning around the financing, actually on the economic side, we saw more studies about the economic impact, so post-study and not studies directly supporting or a utilization of such a measure in the commissioning phase. And so here we go back to what Professor Rawaf was clearly raising. We can use this measure for cost utility assessment or cost effectiveness, but how can this inform the continuous commissioning of services? So I would like to have your brief feedback out of this question, and also let me introduce a final point of reflection, which is about the resources, but also if we say that we want to use this measure, how? Are we talking about developing studies? Because so far we saw studies. We didn't see a case where this measure are part of the routine of the assessment of the statistics in the healthcare system. So we might start it with Dr. Khoja, who is next to me, and he might give also the perspective of Saudi, and then we go through all the panelists. The floor is yours.
Yeah. Thank you very much. I really enjoyed the discussion and the great presentations and experience from different countries and the leaders in public health and population health and people who work on global burden of disease. Actually, when we look into setting the priority and informing our commission, let's say strategic purchasing cycle, we want to do that in a way to reflect the need of our population and to account for that. That's why when we thought of using the burden of disease as a tool, initial tool to form our policy and area of prioritization, we noticed that there is some methodological issues and consideration that we need to take care of it. And it's mentioned already by Verdiana. Other issue that I really want all of you to contribute to are issues related to age adjustment, waiting for the age, the discounting, and also, of course, the disability. All of these decisions, it has an implication, ethical and I mean, on the calculation and so on and so forth. What are the argument for having this adjustment in place or no, and also how you settle this kind of argument at a national level when you decide to calculate the burden of disease. So that's another angle of our roundtable discussion. I believe really we are still in the beginning of our transformation in Kingdom of Saudi Arabia. We wanted to utilize the experience from different healthcare systems to better inform strategic purchasing and to attain the quadruple aim of the health care system. So the floor is for you, and looking forward to hear from your side. Thank you.
So thank you, Dr. Khoja. I may give the floor to Professor Salman Lawaf.
Dr. Salman, you are muted, Prof. Salman.
Thank you very much, Dr. Abdullah. My apology. I think, as I said, and I just want to reiterate this point. I mean, I enjoyed all the presentation, and it gave huge dimension in terms of use of data, and in particular, you know, this global of disease data, global burden of disease data. But I think the issue, which is very important, and I raised it a couple of times, how it will affect policy. I know actually there is an issue from David about whether purchasing was effective or not. I mean, purchasing is not only practice in the United Kingdom, and many insurance companies are doing that and using data and analyze it in different parts of the world. So the big question here, how do you use the data available to us and the things which are presented to influence policy, to address the issues of inequalities, to address the issues of access, improving universal health coverage, shifting the agenda from healthcare to health, focusing on prevention by preventing people from entering the hospitals, which is saving resources, but also preventing disabilities. I mean, this is not about celebrating about the magnitude of disability, of magnitude of disease. We should celebrate the way we can prevent these diseases. And this is the aim of public health. I mean, I'll always put 3 circles. Our aim in public health is to maintain people living a healthy way, good quality of life, and prevent the disease and disability. I mean, these are the issues which really need to discuss. Yes, some of the data available, this is the global data, which is global burden of disease, but as I said, this is not a precise data, these are estimates. They are very helpful to guide me in certain things. But would it help me, and I put myself in that position, would it help me when I was in London, in South London, Southwest London, responsible for the health of the population? Will that data help me in making the right decision? That is really the question which we need to address. Thank you.
Okay, thank you so much. No, it's very clear the point. So how this can address all of the different questions or for the everyday also management and the running of the services. So this is also what you're correctly raising. So I would love to give the floor to Professor Signorelli, so to have also your feedback and insights on that.
Thank you very much. Thank you very much, Verdiana. And I think it was a very interesting meeting today from different point of views, where it seems that the Kingdom of Saudi Arabia need to plan also the collection of high quality epidemiological data. It was very interesting, the last presentation from the colleague from Erasmus University, where the lack of a disability weight from the area seems to be quite important in defining health needs for certain kind of diseases. And probably the importance of segmentation seems to be a priority in a country like Saudi Arabia, with a lot of differences in terms of cultural and social characteristics of the population. In the projection of the trend and the burden of disease in the next years, we have to consider with a lot of interest the presentation of Alessandro Cassini, because Alessandro Cassini showed that in a country, in a continent like Europe, and the experience of the European Agency for Infectious Diseases seems quite clear that we, even if the incidence and mortality of infectious disease seems to decrease, we have 2 or 3 infectious diseases such as HIV and tuberculosis, the most important, that has to take into consideration. And again, as in my presentation, I would like to stress the importance of prevention and vaccination campaign in order to reduce the impact of infectious disease on the health of the population. In other words, it seems to me that such exchange of experiences is a good way for future actions, where probably also the experiences of different health services can help in the next future for the decisions. And again, maybe there will be other opportunities also to describe in details the activities of the health services organized in a different way in different parts of the world with different health problems.
Thank you. I would love to have the feedback from Professor Nomura and Yoon, who actually have experience on this national calculation. So what was the impact, the real impact that you experienced for the priority setting? Which are your advice considering to start from the scratch? And particularly for if we consider from the payer perspective, because what we are actually questioning now is not the utility of building such a measure, but then how we can actually utilize them in priority setting and to and towards a value-based allocation of resources in the healthcare.
Thank you very much. So I think in order to maximize the impact of burden of disease study on health policy, I think it is quite important to know the knowledge gap between the disease burden based on data and our just perception based on just our experience or something like that. For example, in Japan, everyone, including the government people from the health ministry, understand the cancer and the cardiovascular disease are very important, but less attention was paid to dementia and Alzheimer's disease, which is now a leading cause of death in Japan, but nobody knew that. And then the GBD result found that, and then we now understand, okay, dementia is now very important disease in Japan. So this kind of knowledge gap should be solved out. Otherwise, the knowledge gap result in less effective interventions. Also, it is important to know the regional difference in terms of the disease burden. So the good things about burden of disease is the variety of comprehensiveness, also the comparability. In Japan, some prefectures have like sodium intake is the leading cause of death and diarrhea, but in other prefectures, metabolic risk factors are high, because the culture within the country are a little bit different. So in summary, my point is that we should know we have the knowledge gap, and then we needed to understand the knowledge gap based on the burden of disease study, which will maximize the impact of the burden of disease study in the health policy making.
Okay.
Yes. So follow up on your comment. Now we use the disability. I mean the burden of disease to inform the policy and where we should focus. What's the experience in different countries and in Japan in using these measures to, as Dr. Salman asked, and he put it in a very beautiful way, the commissioning, and we are moving toward value-based healthcare. How can we use this to assist the performance, pay for performance, introducing some target on the providers, and for public health, of course, large-scale effectiveness. How can we use it? Should we use it to start with? So these are other questions and other angle that we want to examine and learn from other people if they had an experience with that.
Thank you very much. As far as I know, more than 10 years ago, most of the policy making are based on the mortality mortality only. But currently, people are not easily die, and then survivorship is very improved. Also, a healthy life expectancy improved, but just life expectancy also improved. And then people will have the bunch of multi-morbidity. So then the importance of disability increased in Japan. And then now we are looking not only mortality, but also disability. And then we realized that if we look at only mortality ranking, like dementia, cardiovascular, cancer, these are top ranking. But if we look at disability, such as YLD and also DARIs, low back pain and the sense organ disease, including age-related hearing loss, are very important cause of diseases. And then now we are now finally making attention to that, because the disability is more likely to be related to the health system burden rather than the mortality. The hospitalization may be highly influenced by mortality impact, but the disability impact. So the point is, again, the government people who are involved in the decision making needed to understand how the DARIs means, and then why DARIs are important, and then what the difference between mortality ranking and DARIs ranking, and then how the health system is influenced by not only mortality but also the disability. So the improving the understanding within the people involved in the decision making is quite important. Even if the researcher understands that, the government people do not understand. So the communication between the health people, the researcher, and the government people is very, very important.
So somehow you're also saying the disability nowadays, with this high life expectancy, is a better measure because it's a proxy then of the utilization that I can expect. So as investment, am I correct? I understand well. So when you come then on the specification of services, so we go back to the question if it can serve or not decommissioning.
I cannot say which is better. Both are important, mortality and DARIs. It depends on what we'd like to see.
Okay. Dr. Awaf, yes, please.
Yeah, I think you are possibly talking at two stages. When you think about whatever effective, I read David Hunter's note, whatever effectiveness of the commissioning or purchasing process, but it is common practice now in many countries around the world. We may disagree about it. But the reality is, when you think in practical terms, step one is about resource allocation to local level, because purchasing cannot be, except for rare diseases, cannot be at national level in a big country.
If you talk about Saudi Arabia, you are over 30 million population. So you have 21 districts. So you need to allocate the resources to these districts. It needs to devolve. It needs to be a devolved function. So stage number one is really about resource allocation. And of course, disability weight and burden of diseases will help you in resource allocation. So those more disadvantage require more resources. That is at that level, the global burden of disease data, although they are not precise at all, they are extremely helpful. The disability weight are extremely helpful and give and take in terms of resource allocation. When you come to the nitty-gritty, which is phase 2 or the second level of purchasing or commissioning or whatever you want to call it, or agreement or bilateral agreement, or ensuring that resources flow to the health settings, you require different type of data. And this is really about activity of data, is about financial data, and these tend to be historic. You build the prediction. If you remember, I said some prediction, and this is the art, and there are a lot of mechanism and formulas to predict, changes in health service need. And here you enter a third dimension, which is the local need assessment. Could be for specific diseases, could be care groups, could be for entire local population. Over.
Great. Thank you so much. I really appreciate this point, not be passionate on a such country-wide reform, but going to distinguish the different level. So Professor Hunter, I would love to have also your feedback and thanks also for all the failures and point of attention you gave to us for a very clear view on population and system-wide transformation process. So please, the floor is yours.
Thank you. Well, just to come in where Salman left off, I mean, he's absolutely right. You do need to push commissioning, purchasing down to the local level. And that's what we did try and do in the UK, United Kingdom. I can't speak for other countries, but where we failed, I think, was to not invest in commissioning and purchasing. We didn't include enough time, money, and human capacity to allow commissioning to work and purchasing to work. We expected too much from too little, really. And even where the information and the data were there in place and could be used, not everywhere, but where there was robust information systems in place, there was still a lack of skilled people to use that data appropriately in terms of what needs assessments were producing. And I think Salman made that point too, that needs assessment hasn't been well implemented in the UK. But it's not just about skills, it's also about working across the whole health system in partnership. And again, we failed to join up the system in a way that allowed health rather than healthcare to be the focus of attention. So the default position was to continue to invest in hospitals and beds and not invest enough in the wider health system and the determinants of health. And as a result, we have widening inequality still. We have among some of the worst health inequalities in the world, and certainly in Europe. And Michael Marmot has documented these over the years. And yet we have the evidence and the data to challenge these, but we aren't doing it. And why aren't we doing it? Well, political will has to be one factor. Organizational culture, we haven't, I think, got a workforce in health that thinks about health in the broad sense. They think about their own little bit, whether it be in primary care, secondary care, or social care. We don't look at the whole system. We're trying to move towards an integrated care model, which will attempt to do that. But it's not just about structure. You have to train people to think and work in a different way culturally. And that's where I think we need to make the investment. And if we did that, I think we could then see some real results in commissioning. But at the moment, policy responses are falling far short of what is needed and what we know works. And for example, take obesity. Obesity is a big issue in many countries, particularly childhood obesity, which has been growing, and even over the last 18 months with the pandemic, it's grown even higher. We know what we could do to invest in tackling obesity, but we tend to not do that. We invest in individual behavior change that we know has limited results. Whereas if we were to invest in taxation, in controlling food supply, in regulating the market, in reformulating food, we'd actually achieve much bigger gains. But we don't tend to invest in those policy interventions. We tend to go back to the easy option of influencing behavior change, which doesn't really, at an individual level, which doesn't really achieve very much. So the political will for change here is critical. And only then, I think, can we then access and utilize the data and information in a way that can maximize health improvement.
I think, David, I fully agree, and I'm really very grateful you raised this point, which is about the cultural change. And I think the Kingdom of Saudi Arabia will face huge challenges in terms of changing the perception of the people, especially the medical profession, which is really, they are geared toward secondary care.
Yeah. Yeah.
And they are, it's a problem with their medical schools as well. Their problem, they are actually immersed in disease models. You know, I evaluated the Saudi health system twice. I reviewed the last one with Dr. Abdullah's father, my good friend, Professor Khoja, Khoja, and in 2009. And you find a huge amount of waste. There are little attention to health, as you mentioned, and no investment actually in health, little investment in public health.
Absolutely.
So it need hopefully the COVID now, through COVID, we learned a few lessons around the world, but unless you have that cultural change, nothing will happen. Data are tools, you know. It depends how to use it. It's not only how to use it, whether people understand what is it for.
Exactly.
and I think unless you know, I mean, most of the policy makers are not trained in terms of data analysis or data interpretation, and not necessarily they value it or they put it in the right place for the right purpose.
Yeah, it's clear here in Saudi Arabia now with this transformation really, and clear direction from the custodian of holy mosques and Prince Mohammad bin Salman, and the vision that it's put forward for the country to focus on the social determinants of health, the society, the whole healthcare transformation. As Prof. Hussam and Dr. Abdulrahman Alqahtani in the introduction, they describe it. It's basically about population, about integration. It's integration beyond the people who are working or the player in the healthcare system. We have to go beyond that and learn from the different people experience and country experience and health system experience. Hopefully, with all of these efforts and the learning from the international experience and from our experience, we will have a better public health and population health policy programs and direction toward improving the population health, better care, containing cost, and of course assuring the happiness of the healthcare providers. So really what you mentioned, Prof. Salman, it's very critical, and considering that in the whole transformation is essential for success. It's a recipe of success.
I'm glad to hear that. Very good.
Yeah, sounds good. There's a wonderful essay in this week's New Yorker by Atul Gawande on Costa Rica and how they've avoided going down that trap of investing in secondary care. And their health status is way ahead of the United States for a fraction of the cost. And we can learn from countries that are not that well developed. They have actually lessons to teach developed countries that we're not paying attention to because we have too much invested, as Salman said, in training doctors in their own way for a job that's now quite different. But Costa Rica's avoided some of that. They've they've leapfrogged over the developed countries to do things in a way that developed countries are trying to do, but are struggling to do because they're too much invested in how they're currently doing things badly. So it's a wonderful essay if you have access to the New Yorker this week.
Sure. Thank you for sharing that with us. And that's basically why we are having this kind of discussion and this seminars. We want to utilize to be innovative in utilizing different approaches, learn from people, get their insights. So it's over to you, Mariana.
No, I would love to hear from Alessandro Castini and Juanita Axma. So what you think, knowing very well the methodologies and how to utilize or carrying out such a study, if that knowledge gap that was addressed by Nomura, but also Salman and
incidents from the case fatality rate, which is estimated to be 0.02%. Botulism,
okay, sorry. I was saying, so if that kind of knowledge gap, but also the not only considering at a high level, but being able to address the right policy that can impact the health, the population health. So we talk about now cultural change, going more in not only a disease base, but moving also out of the diagnosis as we used to assess them in the past, or the mortality focus. So do you think that actually this measure can be of help in that?
Well, thank you very much, Verdiana, and to all the other panelists. It's been fascinating listening to the discussions until now. It was reminding me these last few minutes when Dr. Hunter and Dr. Awaf were talking, reminded me also of a few discussions I was having with Professor Signorelli when I was still studying. And I'm young enough to even have studied on his books. He reminded me, now that you're stopping clinic, because I used to do surgery. So now that you're stopping the clinical work, remember the biggest challenge is that you're passing from a passive state of just waiting for patients to come over and ask for your help and your services to an active state. So now you're actually going to have to work actively for prevention, for public health, for finding out what are the issues, finding out what are the best interventions, how to do that, how to estimate, how to do epidemiology, because he taught me the epidemiology side of the work. But it's fascinating because our jobs involve many different areas, from social sciences to economy to behavioral studies to policies, etc. So this really started me thinking about the leadership environment that you need around you. And it seems like the Kingdom of Saudi Arabia and the providers and payers that are involved in this workshop seem to be open to our discussions and to and more evidence-based approach towards deciding how to allocate the money, what to do with a finite number of resources. So I think that's promising, and that is what you need, the initial really kick that you need and the environment that you need. Otherwise, you won't have the money to actually do the work, the money to collect the data, and as you very properly said, data is just a tool. It's what you do with that data that really counts. And obviously our job is to try to translate that data in order to make it significant and then help you identify what are the best solutions. But then to decide on what are those solutions, it's more your job. On the other side, or let's say together on the same side of a round table. And to do that, evidence is going to be crucial. Probably not the only element that will need to be considered because there are values, preferences, and as much as we can work on disability weights to reflect those values and preferences, there are many other factors related to culture, to values and preferences that cannot be captured, but that you as the final decision maker will have to consider. But if the starting point is the evidence and the data, I think that is a winning position to be in. And your example, Dr. Hunter, on Costa Rica, I think it was that you were mentioning, is a perfect example of a country that had the opportunity to maybe start from zero after the experience of other countries, and that could learn from other situations and see that if you start from the beginning without that huge investment in tertiary care, there's so many other opportunities that are out there. I wanted to anchor also this on using the estimates at the local level that Dr. Waf was talking about earlier. It's true. At the end of the day, the more operational decisions are made at the local level. And how much is what we're doing at this global, continent, or even national level, how much is what we're doing really useful when you have to make some very specific decisions, operational decisions at the local level? And let me argue that it's this approach, first of all, introduces the concept of using evidence to make your decisions, and shifts the culture towards that direction. I think that is very important. So maybe our estimate on the fact that the burden of healthcare-associated infections are actually huge, and that we should focus a lot on infection control in healthcare facilities, and maybe also more in preventive measures at the community, might not be useful for all the counties or provinces that are involved, but the approach, the idea, the methodology, the culture shift is still very useful. And then also, obviously, just the actual methodological approach. Last, but not least, is something that Carlo, that the Professor Signorelli was talking about at the beginning, which is the quality of the data. Now, I don't want to get into too much technicalities, but if you don't invest in surveillance, in providing good quality data, it's hard to do any of the things that we've been discussing this morning / afternoon. This is extremely important because Saudi Arabia has the potential, already has quite a lot of surveillance data available, has the potential and has the resources to invest to even improve the quality of the data. If it's good data coming in, it's going to be good data out, and that really makes the impact and makes a difference in terms of the decisions that you need to take. So I don't know if I answered your question. Sorry, Verdiana, was going on my own path, but hopefully, but you can ask again if I haven't. Sorry.
Absolutely, I think you touched the points, and also there's again some content. Or indeed, I like the idea that today, for taking decision, we need to have evidence. I mean, also in the leadership study, this is becoming the hallmark of the new system leadership that is needed, because with evidence you can build on a consensus. So I like really this idea. And then I would like to hear from Juanita, Professor Juanita, on the same point. So if you really think that building local, national measure, especially the disability weight, can then support the policymakers closing the knowledge gap that we were talking about, and if yes, how this can be actually put forward, because we talk about challenges, we talk about resources, and if we look into order of priority and we have in mind a road of implementation, considering the current situation of Saudi, is that the first step that you would recommend or not?
Yeah, well, thank you very much. And thank you for this summary also. I really liked all the points that were brought forward, and I actually agree with all of them. So yeah, little for me to add, I think. Firstly, yes, I agree with that is very important at the local, national level to have information to guide policy making. Of course, I think, and also quality data is very important. I think one thing that stood out to me and that I think is one thing maybe I never paid too much attention to when teaching, for instance, about burden of disease studies is the need for the involvement of stakeholders. I think this was also mentioned by you, the previous speakers too. So it's very important. Actually, a first step of a burden of disease study is to make a stakeholder analysis and to see which players are all in the field. So it's not only the policymakers, it's even people from the population. And I think doing a stakeholder analysis and assess the needs of these stakeholders, of all these stakeholders, including the doctors who are on the floor, including the policymakers at the municipal or the small local level, to include them all in this stakeholder analysis and assess their needs and what they expect of such a study and involve them in the study. I think also involve them at each of these levels that Professor Rawaf was talking about, the higher level and also the lower detailed level, involve them in each of these steps. So also decisions on a disability weight study, for instance, which is at a more, I think, later stage, also include stakeholders in that phase of the study, I think. So that was actually what I thought about. And then it's important, like Professor Nomura also pointed out, that it's important to bridge this knowledge gap. So if you have these stakeholders, you also want to communicate, first of all, the aims of the study and why you're doing the study, but also afterwards communicate the results of the study. And I think Alessandro, but also Professor Nomura showed some very nice examples of communication with very nice interactive graphs, and maybe even invest in short workshops to help them use these graphs to bridge this knowledge gap. And there's actually a whole, because you talked about the burden of disease network in Europe, where I'm a chair of one of the working groups, but there's actually one working group that's all about knowledge translations to those stakeholders. So I think that's a really important aspect to take into account for this kind of huge project that you're embarking on. Yes. I also don't know if I answered your question, but
I think it's difficult to have a full stop question and answer in such a debate. But let me move to the second point of our discussion. So to try to, now, if we know these are the different challenges, so what you suggest actually to be the roadmap of implementation? So what could be the first step, knowing also that on one hand, we have to cover this knowledge gap, but we also have to consider the challenges of the implementation, the infrastructure that is to build. So, for instance, were mentioned tools like the health need assessment, as well as other measures. So what could be the right roadmap considering both? So the practical approach, what can be done, what are the resources that we can put on the ground right now, and then a long-term perspective, which has said a country such as Saudi Arabia, it's sort of to go towards a big transformation. I want to introduce to you also Professor Brecht de la Fcher, who joined us right now. He is a senior epidemiologist at Shenzano and a visiting professor at Ghent University. He was responsible for the European Burden of Disease Network. And I would like also to hear from you, so maybe you can start or being the first to break the ice on this question. Thank you so much for being here.
Yeah, thanks a lot for the introduction. Can you maybe be a bit more precise in what the question is about?
Yeah, so we discussed maybe already what about the challenges and the roadmap to implement the utilization of summary measure of population health, particularly on a national level. So what could be your suggestion in terms of getting a roadmap where to start from to build the infrastructure beyond the culture, as we were discussing straight now? So particularly, what are the kind of data that are needed? And if these are not there, what you suggest to start from?
Yeah, thank you. So in any case, it's important to realize that these kind of studies are always iterative processes. So we sometimes look at the GBD study and we are overwhelmed by the amount of information and estimates that they are able to provide. But it's important to realize that this effort has grown over the past 20, 30 years. So it's very important when you're embarking on a study that you take this perspective into account and that you don't feel frustrated by the fact that you will need to take time to get things started, but you need to realize that it will be an iterative process where you will be able to fine-tune and improve over time. So this is already a very first important message. In terms of data needs, and this was also referred to by Alessandro, I sometimes present national burden of disease studies as the cherry on the cake of your health information system. So doing a national burden of disease study allows you to leverage the quality and the potential of your national health data system. But at the same time, it also helps you to further improve and develop and fine-tune your national health information system. I can quickly share one slide where I give an overview of some of the key elements of any national health information system, starting with your vital records, which give you important information on very basic demographic facts like who is your population, how many people do you have in your country, how many people will die per year, what are the causes of death. So having complete vital records is already a very important first step in building any national burden of disease study. And then, of course, we also need information on specific diseases, and these can come through a variety of sources, through medical records such as hospital discharge data or GP records, claims data if you have a national health insurance system, specific surveys, surveillance systems, specific disease registers. So all of these elements will build your national health information system, and the quality of your health information system will, of course, depend on the availability and the coverage of these different sources, but it will also depend on the potential for establishing data linkages between these different elements, because some diseases are best captured in some sources, but not in other sources. So if you want to have a complete picture of the true impact of different diseases, ideally, you are able to link up these different data sources to get a very complete and comprehensive assessment of the descriptive epidemiology, basically, of the public health aspects in your country. And your burden of disease study will take advantage of the availability and the quality of this system. It will also help you and even force you to further improve the quality of your system to see where the gaps are. And one important element, and maybe that's a final element then in my intervention, an important aspect is that a national burden of disease study also allows you and even forces you to build interactions with the different entities within your country involved in public health. So it's very useful and beneficial to have a steering committee or a follow-up committee where all of the different data holders are represented, also where the different end users are represented, so that you can work on this as a joint activity, because you will be needing a lot of data from different actors. It will be a joint activity, but also the results will need to be translated to the people who will need to act upon those data. So doing this as a collaborative effort is probably the most efficient and the most sustainable way forward. And again, to finish with what I said in the beginning, realizing that this is an iterative process, so you will start with whatever you can, But then as time goes by, you will improve, you will add detail, and you will build up this process as a house of cards that keeps getting bigger and bigger. So thank you very much.
Thank you. May I give you one question that we received from the chat? So related on this, they're asking what to do currently in Saudi, where most of the data not only are limited, but are mostly dependent from the health facilities. So even compared to the panel of data you show.
Yeah. So it's true that in the European countries represented in the European Burden of Disease Network, we typically have a wealth of data available, although there's always limitations and gaps, so that's inevitable. But again, the first step is, I believe, to see what is possible in your own setting and to start with what you have, to just make the very first steps based on what you have, and then to continue building on the future steps. So every country is basically faced with this same question, because there is no one country in the world that has a perfect health information system. There will always be gaps and limitations. So the challenge is always how to make best use of what is available, to come up with a first set of estimates, and then gradually build and use this experience to foster the further development of your health information system.
And regarding this, then the utilization instead of data for the financial assessment. So how this connection is at the current time good enough? Because as we were discussing right now, most probably most of the data feeding the construction of a summary measure of population health are focused on population health assessment, but not on the, they're not taking into account measure from like the claims or other information for which we can in the future utilize maybe the same metrics for performance assessment and into commissioning. So
yeah, but claims data can also be very beneficial for population health and descriptive epidemiology. So depending on whether your system also integrates diagnosis in the claims data set. If this is the case, then you do have a rich source of data. But even if you wouldn't have diagnosis integrated in the system, you would be able to estimate the prevalence of a number of important diseases based on claims data. The limitation, of course, will be that you will then only capture the part of the iceberg of patients that are seeking and receiving healthcare. So that's one thing to be cautious about. But the challenge is always to have a good understanding of what is available, of the advantages and disadvantages of what is available, and then to start building on that. For economic assessments, probably very similar advice would also hold, that the first step is always to see what is available, what is possible in your country, and then to launch yourself in the exercise. A danger that sometimes arises is that people want to first think this through in a too much detailed way, and then they will come to the point where they say that the context doesn't allow to make any estimates. But this is again this idea of an iterative process. You start with what you can do, and then you build on this for the future waves. It's never possible to start with something that will be perfect or close to perfect. So it takes a lot of time to gradually improve. And this is true for any country, and also for the Global Burden of Disease study, which, as mentioned, had the advantage that they were able to start already 30 years ago and gradually could improve in scope and depth and detail.
Another question related to the data based on the experience in the European network. What about the legal framework that are necessary? So what you see from the different countries in Europe could be one strategy, or also an experience to look at, because also the legal framework for the data utilization in the country is still under construction.
Yeah. So yeah, the legal frameworks are of course there to mainly to protect the privacy of the individuals behind the data. And when there is a legal framework, it also typically implies that there is a privacy body or commission that will assess whether or not a certain access to data can be granted and under which conditions. So the legal aspects have their place, but they shouldn't stop you from accessing and using the data for purposes of scientific research. And one important aspect there is the potential to set up data linkages, because this leads to even more advanced privacy issues and even concerns. So there it's very important to know what is possible from a legal context to set up linkages, ideally in a routine basis, if not in a project and ad hoc basis. But your legal framework shouldn't prevent you to do scientific research, of course. It should be there to safeguard the privacy of your population.
May I ask that if we focus on using the data for setting priorities, because this is the topic which we are talking about, you know. This is not about research, you know. We need to look at some practical experience of colleagues across Europe, across Far East, the United States, who are able to use a global burden of disease data versus local utilization data and vital statistic population data, etc. I mean, we need to learn that in terms of how they did manage to set the priorities for their health system, moving into planning and policy decision, and more specifically into commissioning services. And I think, Abdullah, this is the main ethos of this meeting and the interest, you know. I mean, so far I didn't hear anyone telling me how to use the, which I love, by the way. I'm part of it since it started with Chris and Ali Muqdad and other colleagues, but and I involved with them in terms of how to use the data in policy decision, and we did have several meetings, but yet I didn't really so far seeing a practical example, people telling me about their research and fantastic results from this research, which are very, very beautiful and very nice. But how do I use it if I'm a director of health in one area in Saudi Arabia or in Chad or in Vietnam? How do I use these data to make a decision for the interests of my population? How I set priorities, how I plan services, how I shift resources? These are the questions which we need to address, in my opinion.
No, thank you. That is exactly the point that we were asking before. It's going to be a study, or can it enter into the everyday policy making? So yes, of course. So what is your answer on that, as you open and break the ice on this point?
Policymakers, I mean, my answer to this, policymaker, they may initiate a study for a specific question, as I use the example of Southwest London for heart diseases, but they are not initiate studies for the entire population, because what does it mean? What is the research question, and what is going to address? I mean, that is the important things if you think about it. I'm talking as if I'm wearing the policymaker decision, you know.
Yeah.
It would be more convenient, let's start from the health need assessment, then starting from, as a policymaker, from one of these measures.
That's what we need.
So
maybe if I may have...
Yeah, go ahead, please. Yes, the questions raised by Prof. Saman Rawaf is basically the essence of this discussion. How can we utilize the summary measure and to move forward with the value-based healthcare? And what are the experience? Is it worth to do it or no, or it's too early to start that? Some of the example that you showed from using the infectious disease, it's really a practical examples. But if we can have more examples on how the payer and the provider use those insights at a local level, that would be great. If we can start discussions.
Professor Cassini.
No, sorry. I think Dr. Abdullah wanted some other examples apart from the ones that I was showing earlier, just to summarize them very quickly. With the way that it worked in Europe, it was slightly different. It was more a push from the Public Health Institute of Europe, which is the ECDC, to provide this data. Obviously, the end game was to try to influence decision and policy making in health, and also to look at the status of the quality and availability of the data. It was not commissioned by a policymaker, which is what is, I seem to understand, happening in Saudi Arabia. So what happened was that when we actually did these estimates, we did have to work quite a lot to try to make the policymakers aware of the fact that we had these estimates. And then little by little, they started to be used on an ad hoc basis. So for example, they were looking at legislation on poultry, and that's when they asked me to do the burden of foodborne diseases, and Campylobacteriosis was targeted. Some countries like Slovenia, the example that I showed, were looking at providing vaccination, and they were asking, who should we vaccinate? And then another example that I didn't show was that Switzerland was looking at how to improve its health more in general. It was like a big workshop. We showed that healthcare-associated infections, this was just before COVID, that healthcare-associated infections were very important, were representing a very important burden, and they came up with the minimum standards for infection prevention control in hospitals. And they have just been recently implemented. So it really depends on the landscape and the environment that you're having around. And that's something that I think we were discussing earlier as well. In this case, it's the provider and the policymaker that are asking, should we go in this direction? And I think already it's a great, signal, the fact that you're asking, and that this is one of the routes that you want to undertake, because it means that you already have a strategy in mind, or at least a scope in mind. And if I can also complement your decision or your approach, I think going towards an evidence-based approach is not only a smarter way to do it, but it will also provide you with the actual evidence and the data that you can use to make some decisions. Obviously, it's not the only numbers are not the only reasons you will make some decisions, but it's really going to give you the right weapons to make to understand where you're going to be able to save lives and save money. So just to underline this again and highlight the fact that with leadership and decision makers already on board, I think you can go very, very far. It's a crucial step.
Yeah. So let's hear from our colleague from Japan and North Korea, what actually was in their experience as they built a national tool. So which was the commitment from the policymaker to develop such a project? Because I think North Korea was also a research project to talk about grants, and the same from Japan. So how you actually, which was the initial commitment, which was the engagement of the decision maker, and then the impact and utilization?
Thank you very much. I'm Shuhei Nomura. In Japan, the government has very, very strong control on the data accessibility. There are a bunch of data, survey data, registry data, cohort data, but if the government do not allow for the use, nobody can access it. So in case of my previous study regarding the agreement between the research funding, also DARIS, the request comes from the government, and then I had access to the data. So originally, the first interaction between the government and me was occurred from the government. So yeah, another case is that, for example, the National Cancer Center in Japan has a cancer registry data. This is a really wonderful data. This is not the mortality data, but incidence data. So very, very good, important data, but that data is not available to the public. The cancer center always try to publish the data to the public, but there is very, very strict rules, and then they cannot publish the data. So we needed to fill out the bunch of documents, application material, and submit to the cancer center. And then the peer review period is a couple of months, sometimes more than half a year. And then finally, we get some aggregated data or individual level data, depending on the purpose of the use. And then after that, after the approval, we needed to submit again the bunch of documentation to the government. This is really hard work. The bunch of the human resource will be consumed. So that
it worked like a kind of dedicated targeted project and not something that goes then in the direction of entering into the policy making. Am I correct?
Yeah.
And then the utilization, what was the utilization? How does inform, as we understood, the priority setting, shifting the allocation of resources, or it goes also beyond that?
Sorry. I cannot see the clear changes because the burden of the study is just one of the benchmark for the decision making. And then the government also do not say, thank you very much. Our decision was based on your study. You are based on the burden of disease. So I cannot say that policy has changed based on burden of disease, but I'm thinking the government considers the burden of disease, which was also clarified in some government document.
Shuhei, good to see you again. Hi, how are you?
You remember me. Thank you very much.
Lovely to see you again. The question for me is, you conducted a study with the permission from the government, because I know in Japan, government control the data. You're absolutely right. And you did an excellent study, but did it serve any policy? Did it really influence priority setting? Did actually make a change to current policy within Japan? Because cancer registration, as you said, is a minefield. It's a beautiful data. And it depends on the way people analyze it. It could serve a lot cancer patient in variety of way. For example, you could decide on centralization of cancer services for more effectiveness. This is only one example. So did you use it for that?
I am not 100% sure that the policy changed based on my burden of disease. The policy formulation take a long year of time. If we look at the allocation of research funding 5 years or 10 years later, and then we can see if the policy changed. Right. So short-term influence may be very small.
Good to see you, Shuhei. Lovely to see you.
What about from Korea? South Korea? We have Minsu, I think, now connected. Yeah.
Hello.
Yeah. Good evening.
Can you hear me?
Yes.
I'm Minsu Ok from Republic of Korea. It's an honor to attend this workshop. And I think there will be a lot of interest in Korean DW research or KMBT study. And first of all, I will tell you about our disability weight study first. And
we already saw it from our colleague before. Now we're asking you what are actually the real utilization of this analysis. So if it actually impact or influence the policy making, or it was committed more in terms of a research work. So how it works, the relationship between the development of this important tool and analysis at the national level and the impact on the policy making.
Okay, we conducted a KMBT study, and the result was included in National Health Plan goal, National Health Plan 2030. 2030 has two goals, and the first goal is extension of healthy life expectancy. And the second goal is an improvement on health equity. And our research has contributed to setting a target for healthy life expectancy. The HALE from our research was about 70 as of 2018, and the HP 2030 aims to extend it by 2.8 years with the goal of raising it to 73 years by 2030. And YLD from our study is needed to calculate HALE, and the DALI's output will be continued to monitor HALE continuously in Korea. And HP 2030 is referring to the result of our study in setting target and prioritizing them, and the results from our research project are being used to establish regional healthcare plan and public healthcare plan. We will continue to discuss the government to refer to the result of the research related to DALI in planning at the national or regional level.
Okay, that is exactly our question. So it seems that we're going to a priority setting on a kind of long-term basis. So of course, these are strategic and very relevant research, and especially if done on a national level or local level. But when it comes to inform the policy making, it seems more going in a quite longer time.
Yeah, but you mentioned something great regarding to the insurance plan. So Professor Yuan, you mentioned that the insurance in Korea, you have a regulator and you have the commissioner. You mentioned that the work that you conducted on burden of disease has informed the plan development. Do you mean the plan, like the coverage, what should be covered, what should be the priority? So one of the area that we are examining right now is what is the scope of service, what is the health benefit package should be covered, and we are utilizing the burden of disease to argue for better coverage, or to set a priority for including some of the services in the benefit package. So did you utilize these insights in making such a decision related to even the health benefit package design, and furthermore in assessing the impact of the intervention at a large scale after 6, 7, 8 years since 2013?
I think let me share with you something, Abdullah. You may find it of some use, and David may chip in because he lived through the same period. If you look at the health service reform in the UK during Thatcher, I was a director at that time, in 88, by early 90s, we introduced the split of purchasers provider, and suddenly all our purchasing expertise was focused on buying a shirt or a trousers from Marks and Spencer. Suddenly we are purchasing things in millions of pounds. So what type of data we used? And the data at that time we used was historical data. And the philosophy at that time was to keep the status quo. Don't shake and break the system now. Give it a time. And it took many years, to be refining the commissioning process. You started to use the data and asking. It's really, Dr. Abdullah, it's about using the data for a purpose. If you don't start using the data for a purpose like planning or commissioning or decision-making, you don't know what type of data you need. And this has come from practice. Gradually, once you start, if you say, look, please plan for a policy development on evidence. And therefore, you will ask yourself, what data I need for policy? For making quick decision and setting priorities, what type of data, there's a beautiful paper from Edinburgh and in Newcastle on priority setting. We could share it with you, and it guided the health services for some years, and the same things for commissioning. You may start within the status quo, keep things as it is, but gradually you start to refine it based on the priorities. You could use disability weight, you could use variety of financial weighing, etc. So you need to be practical, but unless you use it, you cannot value the sources of data and value the data needed.
Can I add a very crucial point here? So we are also somehow mentioning that the utilization of the disability weight, considering the perspective of the payer, maybe in the future can be a good measure for the risk adjustment. Or what do you think on this? Because that could be, as you say, which is the purpose on a medium term of such an investment for going towards this direction?
If the question to me, I already answered that. I think disability weight will be a good measure in addition to many other measures in resource allocation, and allocating resources at national level between various localities.
But not improving the risk adjustment based only on...
It's difficult to use it in commissioning or in policy on specific issues, because you see, when you come to commissioning, it's everything about the unit price, all right? You have to band your services, major, medium, lower, etc. For example, in the UK, we use 6-band. And also in the UK, we use national tariff. So there are no different prices in different places. Both private, public sector use the same tariff, okay?
Professor Hunter, on this, what do you think?
No, I agree with that. I do think when we introduced the purchaser-provider split, there was a power imbalance in that the power actually lay with providers and not purchasers. They had the evidence, they had a lot of the data, and they were suspicious of purchasers because they felt they were going to have their priorities and their projects and their pet beliefs all challenged. So there was a power play between the purchasers and providers. If you have an integrated system, you try and address some of that because you're all in the same boat, all trying to achieve the same things. If you start splitting the system between different components, purchasing and providing, you introduce, I think, power imbalances and barriers to change that are actually unhelpful and can be addressed by not having that separation. And I don't think we've ever overcome that power imbalance between the commissioners on the one hand, who in theory have all the power, but who in reality are dependent on the providers to provide them with the data and information to make their decisions. So exactly. That's been the conundrum. It's not really worked because of that power imbalance. And we haven't taken everybody on board and put them all into the same boat and said, look, how do you manage this place in terms of the healthcare needs of the whole population. So the cluster model that you're adopting in Saudi Arabia may well be one way of overcoming that if you have the whole system approach to leadership and to policy making and to implementation. And I would separate implementation from policy. You can have a great policy and the implementation is terrible. So you have to distinguish between having the policy and then making sure you have the support mechanisms in place to implement it effectively. Because we all have policies that have never been implemented, and they're wonderful policies, but they're pretty useless because they haven't changed anything. So the implementation is a separate issue, I think, connected but separate in terms of what needs to be attended to.
Yeah. Juanita, what do you think on all of this discussion regarding the disability weight, as you have the one with more experience on?
Yes, well, as I mentioned in my presentation, you can use the global burden of disease disability weights. There's no problem with that. Many studies do, even though they're maybe in theory, the preferences of their societies or the society that they study are not reflected well in those disability weights. So I think that's really not a bad option. It's not making your study, if you're going to do a burden of disease study, very much worse. It's just good to be aware of this effect that maybe the preferences of the health of the population you are studying is not included in the global burden of disease studies. So yeah, I think on the other hand, you can perform a national disability rate study, but it will take some resources and also logistics. So not only you need money, but you also need quite some personnel investment for that, I think. It's only temporary because, you know, it's not something you would need in the future, hopefully. But maybe it's good to also hear from Minsu Ok about their deliberations about using national disability weights in their Korean burden of disease study. Sorry,
Yeah.
did I break off? Oh, sorry.
The reason why we produce disability in weight in Korea is because we produce DALI in Korea. We need to apply disability weight in the context of Korea so that we can calculate DALI in the Korean context. So in light of the purpose of MBD, the effort to produce disability weight in the region will also have to continue, I think.
Yeah, so maybe I can ask Minsu if you would go back all the way to the beginning of starting the whole Korean burden of disease study. Would you again do the Korean disability weight study?
Yeah, I will.
Yeah.
I will do own study. We'll produce validated DALI.
Yeah. And if you had really limited resources, because your colleague already told me about the very nice position you had with the funding. If
but
you
Korea
had much,
has a lot of resources, so we can conduct our own survey or analyst team, so we can produce our own disability weight.
Yeah. And in case you would not have the resources for these disability weight study, would it then have been okay for you and maybe the people who, the people who gave you the money, the commissioners, to use the global burden of disease disability weight study? Or would you have not done disability adjusted life year study at all?
I can understand your question.
Oh, sorry. Yes. So am I breaking off? So is my connection really bad?
No, it's
oh, okay. No, maybe just how I formulate my question. Sorry, with the translation.
I got your questions. I mean, we tried to use the global burden of disease study jointly with colleagues in Washington, Seattle, for assessing health system performance. We couldn't, but we managed to get information from HAC, the HAC index, the Health Access and Equality Index, which is a nice index, but it's a bit crude, but it is very indicative. And this was a PhD study based on a request from colleagues in the GCC, which is including the Kingdom of Saudi Arabia. So we managed to compare in terms of population access and the quality of services between the 6 countries. By the time, you know, the study was available, and before publication, of course, the candidate from the GCC got her PhD, which is excellent PhD. Actually, we prepare papers for publication. The policymaker in these countries said, don't publish it, because of the sensitivity between the 6 countries, you know? And at that time, there was some political tension, as you know, within the GCC. And unfortunately, we didn't publish the paper because we didn't want to upset them. The study was for them, you know. Abdullah may be aware of it, but yes, you could use it in limited way, compare it, but provided that the people who are at the receiving end believing in the data, you know. Unless there is that strong belief, then you cannot use it for either comparative study or decision making.
I think if I want to open the floor, if there is any question from the attendees. Otherwise, I think we reach at least an initial kind of consensus on some point. We might reflect a little bit more on as far as it's not something so easy to get on a black and white straight away. For sure, we agree, everybody, about the importance of such a population, of some measures of population health and their value in addressing, prioritizing the health intervention. So no ways it could be also a valuable approach to go for a national or a local study. We keep open to what extent this could be more kind of research study that can support on a long-term basis the policy making, the priority setting, compare instead to the actual capacity to use it in the everyday policy making and more in detail in what is the purchasing and the commissioning. We raise also important elements such as the build of a new culture related to the value-based care, the collaboration, and also the collaboration across different actors. So we talk about the clinicians, the different stakeholders in the system, so not thinking only about policymakers separately, but all the different points and connecting the dots for actually building the new culture. We keep, let's say, more openly what could be a roadmap. So if this is something that goes in the long term and more into building the evidence through research to support the policy making, so what could be instead the a straight and more practical and maybe easy way to build a policy roadmap to build that kind of evidence that can anyway support the national, the single payer as it is for FAP, but also in the logic of the value-based care that the Kingdom of Saudi Arabia is now looking at. So maybe this could be something we can still, and in the future, once we have systematized the first consensus around this key point, we can take further the discussion. So we have different input that derive from today. So the importance in any way closing the knowledge gap with the policymaker. So this is very important. The importance of going locally. So the short need assessment, health need assessment that can be done locally, maybe can be in any way a good guidance for population health measure in the short time compared to the long run of developing such summary measure of population health. So I hope I summarized the point correctly in a balanced way. I would really love to thank all of you, all of the panelists that stay with us for more than 8 hours so far. Thanks from my side, and from all the team, and also from the participants that they also stay with us for such a long time. As said, we will share shortly with everyone the material from the workshop, and for everything else we are available. So thank you once again for this.
Thank you very much, everyone.
Bye. Thank you.
Thank you. Bye-bye.
Bye-bye.
Carlos, bye-bye.
Bye. Bye.
Good to see you. You look good.
Prof. Salman, يعطيك العافية. السلام عليكم.
Habibi Abdullah, bye-bye. Good to see you.
He's also speak Arabic. Oh, wow. Grazie, Prof.
Mi sembra...
Parliamo in italiano?
Abbiamo chiuso?
No, we still have participants and others. So, ok, arrivederci.
A dopo, grazie.